Assalamualaikum everyone. My name is Nawaal Saleem. I'm a third year medical student, and today we'll be exploring the anatomy of the head. So, this compilation of lectures is very easy, inshallah, because you've already done neuro, and this is just like a baby neuro, right? So, if you have any questions, don't hesitate to email me. Now, these lectures are very anatomy heavy, right? So, you just need to focus, and inshallah, you'll get it, right? So, let's start. Bismillah. So we're going to start off with the table of contents. So we're going to start with the skull, the first lecture. This is the bones of the face and the bones of the skull. The second one is the scalp and the face. So we're going to talk about the layers of the scalp and then explore the muscles of the face. Then we're going to talk about the parotid region. So we're going to talk about the parotid gland and then the vascular anatomy of the face. Then we'll move on to the fossa. So we have the temporal, infratemporal, pterygopalatine fossa, and then the mastication muscles. And then the last lecture is about cranial nerves 5 and 7. So we've already done the nuclei in the brain, right? But we're going to look at the branches of these nerves in the last lectures. And at the end of every lecture, we'll be doing questions and answers. Okay? So let's start off with the bones. We have the neurocranium, which is the top part of the skull, and then we have the viscerocranium, which is the face. So the neurocranium contains the parietal bone. So we have two parietal bones over here. We have the frontal bone, we have the sphenoid bone, the ethmoid bone, the temporal bone, and the occipital bone. So notice which ones are paired and which ones are not. The occipital one is not paired, ethmoid is not paired, sphenoid is not paired, frontal is not paired. So just the paired ones are parietal and temporal. So let me just open up the marker so we can draw a bit. Okay. And then we have the viscerocranium over here. We have the nasal bones, which are paired. So these green bones over here, these are the nasal bones. Then you have the lacrimal bones, which are also paired. So the turquoise ones over here. Zygomatic bones, the bright pink, both paired. Inferior nasal concha also paired. The vomer is unpaired. So as you can see, this dark blue bone in the middle, this is unpaired. The maxilla is paired to this orange bone over here. This is paired. And then the mandible is unpaired. You just have like one jaw, right? So moving on. Uh, Now we're going to just look at this in detail. The neurocranium, which is all of these bones, it's going to provide a case for the brain and the meninges. And then it is composed largely of just flat bones, united by fibrous interlocking sutures. So the sutures are what connect the bones. And then you have the diploi, which are the spongy bones, and then you have the cranial base and the cranial vault, and the roof of the cranial vault is called the calvaria. All right, so then we move on to our very first bone, which is the frontal bone. So this forms the forehead, so the forehead and the roof of the orbit. So these are your orbits, so just the roof and the forehead. It has paired frontal sinuses. It develops as two bones separated by the metopic suture. So when the baby is born, there's a suture right in the middle of these two frontal bones. And as a baby grows, it fuses, right? So the metopic suture just fuses. It's not there anymore. But in 8% of the population, it remains open, and it's not a pathology. It's okay. It's just there in 8% of the population. Then we move on to the temporal bone, which is your temple, so like the side of your head. The first part is the squamous part. So as you can see over here, this red part here, this is the squamous part. And as you can see here again, this is the squamous part. This includes the mandibular fossa, which is over here, and the articular tubercle, and this long thing called the zygomatic process. And then you have the tympanic part. So the tympanic part is this blue part over here, this green part on this diagram. This is the floor and interior wall of the external acoustic meatus. So if you have your ear, okay, it's just going to, if you remove the cartilage, it's just this area over here. This is the tympanic part. And then you have the mastoid part, which is this purple area over here. And over here you can see the mastoid. Again, it's purple. So it's like behind your ear, there's like a bony prominence. That is the mastoid part. It contains mastoid ear cells, and if that area gets inflamed, it can lead to mastoiditis. Then you have the petrous part, which is just over here, as you can see, right behind the mastoid part, and it is quite a very hard bone because it protects the inner middle ear, and also it contains the carotid canal and carries the cranial nerves 7 and 8. So you have the facial nerve and the vestibulocochlear nerve. Okay. So let's go one by one. So you have the squamous part of the temporal bone. So you have the mandibular fossa and the articular tubercle. From the names, you can tell it's going to articulate it's going to articulate the temporomandibular joint. So this is the TMJ. So basically, your jaw is going to articulate here. And then it's going to extend anteriorly. So look here. This is the green part. It's going to extend anteriorly and it is going to join with the zygomatic bones. This is the purple one is the zygomatic bone and this is the green bone. So what about this arch, this cheekbone over here? There's two parts to it. So the purple part is the temporal process of the zygomatic bone and the green part is the zygomatic process of the temporal bone. Okay? And that forms the zygomatic arch. Then we move on to the tympanic part, anterior portion and floor of the external acoustic meatus. We just discussed this. And then we move on to the mastoid part. So this contains mastoid air cells. So if you can look over here, let me draw on the page. So these are the mastoid air cells, and this is the mastoid antrum. So this is the mastoid area, and this is the external ear opening. So the middle ear is in the petrous part. So what happens? If there is an infection in the middle ear in the petrous part, it can go to the mastoid because the mastoid antrum connects the two structures. And this happens in otitis media when the middle ear is inflamed. It can go to the mastoid. It can cause mastoiditis, and it's severe pain and bulging of mastoid in kids. So this is going to be very painful. It's going to bulge. Moving on to the petrous part of the temporal bone. This contains the inner ear, middle ear, internal acoustic meatus. So I want you to focus on diagram A number here. Diagram number A. This is number 10 is the external acoustic meatus. It's the external ear. This is a styloid process. This is the mastoid, right? Now, if you flip that in the inside, number 17 is the internal acoustic meatus, okay? So this transmits the facial nerve and the vestibulocochlear nerve, and it's the entry point into the temporal bone. So especially facial nerve, cranial nerve number 7 that we're going to discuss in detail now. It travels inside this middle ear, and it later exits the skull through the stylomastoid foramen. Okay, so what happens if the temporal bone is fractured? So over here, if this area gets fractured, blood and CSF can escape from the ear, and this can cause hearing loss and Bell's palsy. Now we're going to talk about specifically the petrous part because in the petrous part, you have the inner ear and the middle ear, right? And if that's fractured, then the blood and the CSF is going to leak out of the middle ear and the inner ear, and it's going to come out of the external ear. So you're going to see like blood and CSF leaking out. So how do you know it's CSF? It's going to be transparent glucose positive liquids. So that's how you're going to get it in the exam. This is called autourea. And then you have Bell's palsy. Um, so what are the characteristics? You have it's a lower motor neuron lesion. It's going to cause flaccid paralysis on one side of the face. So if the lesion is on this side of the face, then if you try to like smile, this part of the face is going to remain neutral. You're not going to see any changes. It's like there are no changes on this side of the face, and that's the side that's affected. So in the diagram over here, you can see that this guy, he's trying to smile, but this side is not smiling. This is where the lesion is. So it's ipsilateral. Then we move on to the occipital bone. So we have three parts of the bone. We have the basilar part, we have the squamous part, and the two lateral parts. So if you can see over here, this big opening in the occipital bone, this is the foramen magnum, okay? And this transmits the spinal cord, the two vertebral arteries, the spinal accessory nerve, vertebral venous plexus, and the meninges, okay? Need to remember that. This is the squamous part, okay? And it has the nuchal lines. You have the superior nuchal line and the inferior nuchal line. I need to draw these. Wait. Okay, yeah. So you have the superior nuchal line. Why is it so thick? Okay. And the inferior nuchal line. Okay, these are very important. And then the basilar part is going to articulate with the sphenoid. So this one, this narrow thingy over here, this is the basilar part, is going to articulate with the sphenoid at the sphena occipital synchondrosis. Okay. And there's also the pharyngeal tubercle on this basilar part. It's going to articulate with the pharyngeal muscles. And then this is the lateral part. So on the lateral part you have the occipital condyles. So the condyles are where the first vertebra, C1, is going to attach. C1 is also called atlas, and you can remember it with this. So this guy in Greek mythology is Atlas, and he holds up the world for punishment. So if you can look here, this is Atlas. C1 vertebrate holds up the whole skull. Then we move on to the sphenoid bone. This is a butterfly-shaped bone. Very confusing to look at first, but very easy to remember again. So this is the inside of the skull. Focus on this diagram here. This is the ethmoid bone. This whole thing is the sphenoid bone. It's shaped like a butterfly. And the back is the occipital bone, right? Now if you look at the deeper anatomy, the blue part is the body. Then you have the lesser wings at the top, the green parts, and then you have the greater wings, the red parts. And then at the bottom, you have these pterygoid processes. So you have the lateral plate, which is outward, and the medial plate, which is inward. Okay, so just remember that. Um, right, so the body includes the sphenoidal sinuses, the sella turcica, which houses the pituitary gland. The chiasmatic sulcus, where the optic nerves cross, basically. That is the chiasma. And then in the lesser wing, you have the optic canals, the anterior clinoid processes. So you can see here, this is the lesser wing. You have the anterior clinoid process over here. Okay. Then you have the greater wing. You have foramen rotundum, ovalis, spinosum. So you have three foramina here. You have the roof of it forms the roof of the infratemporal fossa and the floor of the middle cranial fossa. So if we just go back for a second, if you look here, this whole area is the anterior cranial fossa. This here is the middle, and this here is the posterior. So in the middle, it's formed by the sphenoid. And now the pterygoid processes are made up of the medial and lateral pterygoid plates. We just talked about this. So this one is the lateral, this one is the medial. And the hamulus, you can see here, this is the hamulus, from the medial plate is going to serve as a pulley for the tensor veli palatini muscle. Palatini. Okay. I hope that's clear. Moving on to the ethmoid bone. Now, this is quite a small bone, but also a very complicated bone. Now, it forms a cribriform plate, which is a roof of the nasal cavity and floor of the anterior cranial fossa. So this, look over here, this is a green one. Now, if you see this line at the top, this is a cribriform plate. And the cribriform plate is called cribriform because it's full of holes. And those holes are going to transmit cranial nerve number 1, which is the olfactory nerve. So that's how you smell stuff. And it is perforated by olfactory foramina for olfactory nerve fibers, just at that. And then you have the perpendicular plate. So this green part at the bottom here, this is the perpendicular plate. So you have the cribriform plate, and then you have the perpendicular plate, and this forms the nasal septum. And then you have the ethmoidal labyrinth. So all around over here, as you can see, where is it, bro? Yeah, so this part here, this part here, this is all the ethmoidal labyrinth. It's called a labyrinth because there's a lot of stuff going on. There's ethmoidal air cells, there's superior and middle nasal concha, and orbital lamina on the middle wall of the orbit. So there's a lot there. Moving on to the anterior cranial fossa. So this is the anterior part of the skull, so like over here. It is made up of the cribriform plate, which transmits the olfactory nerves. So as you can see over here, this is a cribriform plate right here. And the foramen cecum, which transmits small emissary veins from the nasal mucosa to the superior sagittal sinus. So this is the foramen cecum at the top. And then it also has anterior and posterior ethmoidal foramina. So this transmits anterior and posterior ethmoidal nerves, arteries, and veins. So the floor of the anterior cranial fossa, what is it contributed by? This peach area, this is the orbital part of the frontal bone. Okay, so this part. The cribriform plate is in the middle over here, made by the ethmoidal bone. And then you have the body and lesser wings of the sphenoid bone, yellow in the image. So this is the sphenoid, part of the sphenoid. Okay, moving on to fracture of the anterior cranial fossa. So what happens if you fracture the anterior cranial fossa? Okay, now this is very important. Okay. So you're going to have periorbital bruising and raccoon eyes. This is because all the small arteries and veins are going to rupture when this is bruised. There's like a bunch of veins and arteries, like the ethmoidal arteries and veins and small meningeal ones. And those are going to burst, and that's going to cause raccoon eyes. Then you're going to get anosmia. If the cribriform plate is fractured in this anterior cranial fossa fracture, then all the cranial nerve number 1 fibers, which were the olfactory fibers, are going to fracture as well. They're going to burst or whatever it's called, rupture. And that is going to cause anosmia, so you can't smell stuff anymore. CSF leakage. Now, basically, the cribriform plate and the ethmoid bone, they're connected to the brain, okay, by the meninges. So the meninges are going to rupture, then you're going to have CSF leakage down through your nose. So it's called rhinorrhea. And how will you test for the CSF leakage? So it's glucose positive transparent liquid. Okay. Then we move on to the middle cranial fossa. This is so complicated because it's a sphenoid bone. Sphenoid bone is always complicated. Okay, so let's start off with the foramen spinosum. So this is number one over here at the very edge. It transmits the middle meningeal artery. Very important. Number two, foramen lacerum. This is number two over here. Very close to the body of the sphenoid. Nothing really passes through it. In adults, it's covered by cartilage usually. The carotid canal number three is here, so you can see it's quite next to the foramen lacerum. So this transmits the internal carotid artery and the sympathetic nerves. Okay. Then we move on to the optic canal. So where is optic canal? This is number four. So you look, where does it go? It goes over here. So this transmits the optic nerve and the ophthalmic artery. And then number five, you have the superior orbital fissure. Okay, this is very important. Oculomotor, cranial nerve number three, trochlear, four, abducens, six, and the ophthalmic division of trigeminal nerve, so C and V1. So that's going to transmit all of those, plus the ophthalmic veins. So all the eye stuff goes through the superior orbital fissure and the optic canal. Then you have the foramen rotundum, number six. If you can see here, this is the foramen rotundum. It's going to transmit the maxillary division of the trigeminal nerve, so C and V2, and the foramen ovale, which is huge, by the way, like this is the biggest circle you can see here. It transmits the mandibular division of the trigeminal nerve, so that's C and V3, and the accessory meningeal artery. So just pause the video and memorize all of this, basically. Okay. Then you have posterior cranial fossa. This one is very simple. We start off with the internal auditory meatus, okay? So this is over here. It transmits the facial and the vestibulocochlear nerve, so 7 and 8. We just talked about 7 and 8, plus the labyrinth artery. So it goes into the inner ear and the middle ear. Then you have the jugular foramen over here. It's going to transmit cranial nerves number 9, number 10, number 11, and internal jugular vein, okay? Then we have the hypoglossal canal. It's in the name. It's the 12th cranial nerve, plus the meningeal branch of the ascending pharyngeal artery, and the foramen magnum, which transmits, it's a huge foramen, so it's going to transmit the spinal cord, the vertebral arteries, the venous plexus of the vertebral canal. So it's just a revision of neuro, basically. Okay, so again, one more neuro revision. Cribriform plate transmits cranial nerve number 1, optic canal number 2, superior orbital fissure, 3, 4, 6, and V1. Rotundum, V2, ovale, V3, internal acoustic meatus, what is that? 7 and 8, jugular foramen, 9, 10, and 11, and hypoglossal, 12. In case they ask silly questions where they don't give you the name or the location, they just say, oh, someone had a fracture and they lost their sense of smell. Where was the fracture? You need to know all the functions of these nerves. Hopefully you know them by now. So just a revision. Now we move on to the sutures. So the cranial base, okay, so the base is formed by endochondral ossification, and the cranial roof and the visceral cranium is formed by intramembranous ossification. You just need to know those words. Now we move on to the sutures. So this is a coronal suture. It separates the frontal and the two parietal bones. This is a sagittal suture in the middle, okay, and it separates the two parietal bones. And then you have the squamous, which is not shown here, but it separates the parietal and the squamous of the temporal bones. It's like over here. And then you have the lamboid, which separates the two parietal bones and the occipital bones. So in a normal baby, the sutures take some time to close, right? Because the baby's growing and then the head needs to mold and whatnot. But in some cases, the sutures close too early and the brain is still growing, and that causes problems. So the first one is oxycephaly. This is where the coronal suture closes too early and you get a high tower-like cranium. Then you have scaphencephaly. This is where the sagittal suture closes too early. You have a long, narrow, wedge-shaped cranium, and the anterior fontanelle, we're going to talk about that, it's smaller absent. Okay, let's move that away. How do I move that away? Anyway, plagiocephaly. Now this is twisted or asymmetrical. Okay, and this is where one of the coronal sutures or one of the rhomboid sutures closes too early. So it's one side, and that's going to cause plagiocephaly. Moving on to the fontanelles. So these allow molding during childbirth and growth. Okay, so this is like cartilage between the sutures before they close, and basically allows the bones to move around, I guess. So during childbirth to has not hurt the mother and growth to like allow proper growth of the skull. So the anterior fontanelle, this red part over here is the biggest one. Sorry, not this red part. This is the bone. This one over here, this is the fontanelle. It is the largest fontanelle. It's shaped like a diamond, like that, and it closes by 9 to 18 months. And now, if this is small or absent at birth, that means that the baby has craniosynostosis, or microcephaly. Then you have the posterior fontanelle, as you can see over here. This should close by 2 months. If any of these don't close by their times, then it might indicate an underlying hydrocephalus or congenital hypothyroidism. Okay, I want you to look at sphenoid fontanelle over here. Sphenoid fontanelle eventually goes away, and this area is called the pterion. Okay, so let's talk about the pterion. So the pterion is over here, and there's like a lot of bones connecting. Okay, and this is where like they all connect. And this is a very, very fragile part of the skull. If there's like a fracture here, or if there's a blow here, it's going to rupture the middle meningeal artery. It's going to cause an epidural hematoma. So this is an epidural hematoma. It forms a biconvex lens-shaped hematoma. It's like an egg, a very oval egg, I guess. And this may compress the lateral part of the cerebral hemisphere and result in herniation of the brain, which is bad. The patient may have an initial lucid asymptomatic interval followed by weakness of the limb muscles with like they're like, what's going on? I can't move my limbs, and a dilated pupil. Okay, and deterioration of cardiovascular and respiratory function. So I put Hermes over here because, as you can see, he has wings on his temple, and that's where the Greek word pterion comes from. Okay, moving on. How do we move on? Okay. Moving on to the mandible, which is your jaw. We're just gonna look at a few structures. Okay, nothing. Don't start memorizing. This is the mental foramen. So over here, at the bottom somewhere here, you have a hole. It's called the mental foramen. It transmits mental arteries and mental nerve. And then you have the mandibular teeth. So these are your bottom teeth. Then you have the condyloid process. Okay, so this is like the back of your jaw, like where your jaw is attaching to your face. That's the head and that's the neck. And then you have the coronoid process. This is a bit anterior. And then you have the ramus. Okay, so this is like over here, I guess. And then you have the angle. So the angle is like here. That's the angle. And then you have the alveolar process and the body of the mandible, which is like over here. Okay. Moving on to the foramen. Now, so number one is the zygomaticofacial foramen. This transmits the zygomaticofacial nerve. So that's number one over here. Okay, so like over here. Supraorbital notch, supraorbital nerve and muscle, so supraorbital above the orbit, so that's number two over here. Infraorbital below the orbit, so that's over here. It transmits the infraorbital nerve and vessels. And then you have the mental foramen, mental nerve, and mental vessel. So if you just remember the foramen, you're gonna remember what it transmits because they have the same name. Okay? Moving on to the scalp and face. So we're done with the first lecture. Easy peasy. So there are 5 layers of the scalp. Okay? What is the scalp? Let's talk about the scalp first. In the old days, the Native Americans used to celebrate victory by killing their enemies, and they used to like tear out the scalps, right? So you want to know what they were tearing out exactly. So the scalp is basically the structures from the superior nuchal line. So where's the superior nuchal line? It's at the back. Okay, it's in the back on the occipital bone to the supraorbital margin, so above the orbit. So from here to the back, and then laterally towards the zygomatic arches. So it's like this area. And the layers of the scalp, we have skin, connective tissue, aponeurosis, loose areolar tissue, and pericranium. Now, if you remember this slide, you're going to remember the whole lecture. Okay, trust. So as for skin, it contains numerous sweat glands, sebaceous glands, and hair follicles. Connective tissue, superficial fascia containing nerves and blood vessels. Okay, blood vessels. Number three is the aponeurosis. So this is fibrous epicranial aponeurosis connecting frontalis and occipitalis parts of the occipitofrontalis. Okay, so you have the frontalis muscle over here. You have the occipital muscle over here. Okay, so these are the muscle heads or whatever they're called. So they're going to attach here in the middle. And like this area, this is not fully muscular. It's basically the aponeurosis of the two muscles. So that's the third layer. Number four is the loose areolar tissue. This is a very, very important layer because it allows the three more superficial layers to move over the skull surface. So basically, if you move superficial layers, this is because the loose areolar tissue is allowing you to do so. And it contains a lot of spaces. It's like a sponge. Okay, and that's really bad because there's like a bunch of arteries and veins, probably veins actually, going into the brain, like directly into the brain. So if there's an infection in this layer, it's going to go into your brain, and that's going to be really bad. Then you have the pericranium, which is the periosteum covering the outer surface of the skull and bone. So as you can see, SCALP, very important. Sebaceous cysts. This is in the skin first layer because it contains the sebaceous glands. If those become obstructed, it's going to cause sebaceous cysts. If you move the skin, they're going to move with the scalp because it's in the skin. Then you have the superficial scalp lacerations. It can result in severe bleeding because all the arteries are in the second layer of the scalp and they cannot retract because it's dense connective tissue. It's going to keep them open. So if an unconscious patient gets lacerated, he may bleed to death because if the bleeding is not controlled. A very important point over here. Superficial lacerations do not gape because their margins are held together by the aponeurosis. Okay, so they don't gape. They're just if they're cuts, they just stay that way. They don't open up. Then you have deep scalp. These gape widely because the frontal and occipital parts of the epicranius muscle, they pull them in different directions. Imagine there's a muscle here, imagine there's a muscle here. If you cut it, the muscle is going to pull it so that it's going to gape. The laceration is going to gape. And that's pretty much it. Then we move on to deep scalp infections, very dangerous area. Infections are transmitted to the cranial cavity through the emissary veins that pass through the parietal foramina and calvaria infection, blah, blah. So basically, if you can look in this picture, you can see these emissary veins get infected. They're going to go directly into the brain, and that's very dangerous. Okay? Then we have cephalhematoma. This is bleeding between the pericranium, the fifth layer, and the calvaria during a difficult birth. So this results from the rupture of multiple minute periosteal arteries that supply the calvaria. Okay, so how do you distinguish this from other stuff? This is limited, the bleeding is limited over the area of one skull bone. So if this is like parietal, like where's parietal, bro? This is parietal, okay? The bleeding is only going to be over the parietal. It's not going to go anywhere else. That's cephalhematoma. Okay. Let's move on to the facial muscles. Very easy peasy. This is the frontalis over here, okay? It's going to elevate your eyebrow, so it's going to do that, and it's going to produce transverse wrinkles. Okay, then you have the orbicularis oculi. The orbital part, as you can see over here, this one, the outer one. Oh my God, it's red. Anyway, the outer one is going to close the eyes tightly. So if there's like a sandstorm or the sun is shining too bright, it's going to close the eyes. Then you have the palpebral. Palpebral, just remember eyelids. Okay, it's going to close the eyelids lightly. So it's just going to be like this one over here, as you can see, palpebral part, just very lightly. It's going to keep the cornea moist. Then you have the lacrimal. So the lacrimal part of the orbicularis oculi is going to pull the closed eyelids medially. So if you close your eyelids, it's going to pull them medially, so like somehow like that. I'm doing it manually, but it does that by itself, so it's like that. And that's going to move the tears towards the lacrimal puncta. So it's going to help the tears flow into your lacrimal glands or something. Okay. Oh, hold on. Then you have the corrugator supercilii, which vertical wrinkles in the forehead. All right, so then we move on to the muscles of the nose. You have the compressor naris, which is part of the nasalis muscle. So as you can see in the bottom picture over here, this is the compressor naris, part of the transverse nasalis, and it compresses the nostrils, so like that. Dilator naris dilates the nostrils. This is the alar nasalis part. And then the procerus, it pulls the medial eyebrows down. So procerus is over here. It's going to pull the medial eyebrows down, so like that, and it's going to cause horizontal nose wrinkles. Okay. Then you have the muscles around the mouth. Okay, so the first one is the orbicularis oris, which is the sphincter muscle of the mouth. So basically the kissing muscle. So if you're going to kiss someone, you're going to be using this one. Then you have the buccinator. It's used during whistling, very important, and sucking by forcing cheeks against the teeth. Okay, so if the buccinator gets paralyzed, then you can see that if a person has a paralyzed buccinator, they're going to be putting their finger inside their mouth to like take out the food out of their cheek because like it's all collecting over there in the vestibule. Then you have the levator labii superioris. I didn't explain this in text because it's very obvious. It pulls the upper lip up. So levator labii superioris, so upper lip levator. Then you have levator anguli oris, so angle of the mouth, oris, so levator. It's going to help you smile. Zygomaticus major and minor, it draws the angle of the mouth superlaterally. Then you have the depressor labii inferioris. As you can guess, it depresses the lower lip. The risorius draws the corner of the mouth laterally when grinning. So if you like do like a big grin, I'm not gonna do it, but if you grin very widely, you're gonna be using this one. The mentalis raises the skin of chin during expression of doubt. And then you have the platysma, so it tenses skin of the lower face and neck. So this is the platysma over here. It's a huge muscle. Okay, you can look at this diagram, orient yourself, pause and do that. All right, so then we move on to the sensory innervation of the face. This one's very easy because it's all just trigeminal nerve. You can see over here. Don't look at the back, look at the front. So you have the trigeminal nerve. So this purple part over here, is the ophthalmic division of the trigeminal nerve. So CNV1, it gives all the supratrochlear or supraorbital nerves, and all of these as well. So supraorbital, supratrochlear, lacrimal, infratrochlear, external nasal. Okay, so all those nerves. Then you have the maxillary division, V2. It gives all these zygomatico-temporal and infraorbital and zygomatico-facial. So these three nerves are going to supply that. Okay. And then we move on to the cervical, no, the mandibular division of the trigeminal nerve. So you have CNV3. Now this one at the bottom, auriculotemporal, mental, buccal. Okay. So that is the mandibular division. So it just supplies the mandible. It's all in the name. Ophthalmic is around the eyes, like around here. And then you have the maxillary division, and you have the mandibular division at the bottom. If you go toward the back of the head, this is supplied by the spinal nerves. So you have the cervical plexus, which is the lesser occipital nerve, and then the posterior masseter spinal nerve, greater occipital nerve. So basically, all that. Okay. So remember, the greater occipital nerve is over here, C2, third occipital C3, and then these are the areas that they supply. Okay, motor innervation of face. This is done by the facial nerve. So we just talked about the sensory innervation of the face, which was the trigeminal nerve. Now we're going to talk about the motor innervation of the face, which is the facial nerve. Okay, so in your lecture, it was to Zanzibar by motor car. T for temporal, Z for zygomatic, B for buccal, M for motor, M for marginal mandibular, and C for cervical, right? So look here, temporal branches, zygomatic branches, buccal branches, blah, blah. So you have the facial nerve, okay? It exits the stylomastoid foramen to enter the parotid gland. So this is very, very important, very core concept. The facial nerve is going to go inside the parotid gland, okay, as a nerve. And then inside the parotid gland, it's going to branch out, okay, into 5 branches. And then it's going to give these 5 branches, basically. So it supplies all the facial expression muscles. That's the facial nerve, okay? So I just want to read this. Facial nerve exits stylomastoid foramen to enter the parotid gland. The posterior auricular nerve, motor to posterior scalp muscles with a contribution to external, so a nerve to stylo has external stylohyoid, and the posterior digastric muscles. Okay, so this is before it goes into the parotid gland, it's going to give off these 2 branches. Okay, so just remember that. Okay, moving on to the facial nerve. We just talked about it, but we're going to talk about it in detail now. It has 3 components. Okay, so there's a lot going on with this facial nerve. You have the sensory, you have the motor, and you have the secretomotor. The sensory one supplies the taste buds in the anterior 2/3 of the tongue, while the chorda tympani. The motor is all facial expression muscles and others from the second pharyngeal arch. So if you see second pharyngeal arch motor, it's facial nerve. And then secretomotor means secretions, parasympathetic to the submandibular, sublingual, palatine, glands of the nasal cavity, and lacrimal gland. So basically everything except the parotid gland. So it branches in the parotid, but it doesn't supply the parotid. It supplies all the other glands. Okay. Moving on to Bell's palsy. So what happens if these five branches get paralyzed? Okay, so why would those five branches get paralyzed? Let's think about this. This is because they're branching in the parotid. So if something happens to the parotid gland, then all the branches are going to get affected, right? So parotid cancer, inflammation, parotitis, or surgery to remove a tumor. It's going to cause Bell's palsy. And manifestation. So if you ask a patient to smile, okay, one side, they're not going to be smiling. That's because they can't smile. It's the muscles are paralyzed on this side. So they're unable to close lips and eyelids on the affected side. Eye on the affected side is not lubricated, dry eye, because if you remember, some of the muscles lubricate the eye, keep the eye closed and whatnot. Unable to whistle, the buccinator is paralyzed. Chew effectively, again, buccinator. Facial distortion, because you can see here it's clearly asymmetrical. So this is the side of the lesion, okay? Moving on to the facial nerve. Okay, yeah. So I want you guys to know that the manifestations of facial nerve injury depend on where the injury is on the course of the facial nerve. So if the facial nerve injury is between here, this part, this is the internal acoustic meatus, and this is stylomastoid foramens. If it's here in the facial canal, you're going to get a lot of problems. You're going to get secretomotor problems, your glands are not going to work, you're going to get taste problems, your facial muscles are going to be paralyzed. So all the functions of the facial nerve are gone. But if the injury is after the stylomastoid foramen, that means only the five branches that are supplying motor to the facial expression muscles, then you're just going to have Bell's palsy. That's it. Okay. All right. The lymph drainage, this is all just memorization. There are no lymph nodes in the scalp. Okay. You have parotid, which is preocular, so ocular and then so it's before the ear. These receive lymph from the anterolateral part of the scalp and the lateral face. So this is number one. You can see here you have the anterolateral part and the lateral part of the face. Number two is the submandibular. So where's number two? This is submandibular. This is in the digastric or the submandibular triangle. So just have to memorize that. Submental is a submental triangle. It's from the chin, the tongue, the tip of the tongue, and the lower lips central part. And then you have the mastoid, which is behind the ear. So the adjacent region of the head. So number four, this is the mastoid. And number five is the occipital region in the back. Okay? To memorize those locations. And then you have the parotid lymph nodes, special because, let's read, are frequently the first echelon nodes to the ear. So the ear, the cheek, the temple. So this is the temple. The forehead and the anterior scalp skin. Okay, so we're here. So any cutaneous malignancy of these areas, if there's skin cancer anywhere in these areas, it's going to go to the parotid lymph node first, okay? And then they drain into deep cervical. So if you see skin cancer, low-key just put parotid lymph nodes. Okay, but just memorize these as well. Okay. The parotid and the body. Right, so let's move on to the facial blood supply and the parotid gland. So we just talked about the parotid gland, right? We're going to talk about the boundaries. So superiorly, you have the zygomatic arch. So I want you to focus on the diagram. So this is the superior, you have the zygomatic arch. Posteriorly, you have the external ear and the sternocleidomastoid. So that's posterior. Inferiorly, you have the angle and inferior border of the mandible, and then anteriorly, number five, is the anterior border of the masseter muscle. So you see this is the masseter muscle, and this is the anterior border. So superiorly, the zygomatic arch, posteriorly, the external ear and the sternocleidomastoid. Inferior is the angle and the inferior border of the mandible, and then anterior is the anterior border of the masseter muscle. Okay. Now, contents of the parotid. Okay. The facial nerve. We just talked about the five branches inside the parotid gland. External carotid. Now, this is divided into two terminal branches inside the parotid. You have the maxillary branch and you have the superficial temporal artery. Okay. You have the retromandibular vein, very important, and the parotid lymph node. Okay. Moving on to stuff around the parotid. Right. So this is a parotid gland. Okay, and by size, you can see it's the largest gland, right? You have the sublingual gland and you have the submandibular glands, but I want you to know that the submandibular gland is the one that produces 70% of the saliva. So most of the saliva is produced by the submandibular gland, and in saliva you find amylase. Okay. Then we move on to the parotid capsule. So it starts off as investing layer of the deep cervical fascia, so it's basically coming up. It divides into two. So the first one is the superficial lamina of the parotid fascia. It's very strong, very hard fascia. It's also called the parotidomasseteric fascia because it also covers the masseter and goes up joints the zygomatic arch. On the other side, you have the deep lamina. Okay, this thickens over here to form the stylomandibular ligament. It sort of separates the parotid gland from the mandibular gland. And then you have the stellar process, and then joins up to the tympanic plate. And just sort of remember that. Then you have the parotid gland. Very important again. So let's zoom in a bit. Okay, this is the parotid gland, right? And this is the parotid duct. So it passes horizontally from the anterior edge of the gland. At the anterior border of the masseter, which is over here, okay, it's going to turn medially, it's going to go inside and pierce the buccal pad of fat and the buccinator muscles. It's going to go inside the buccinator. It's going to open into the vestibule of the oral cavity. So it's going to go inside the oral cavity. It's going to open in a small papilla opposite to the second upper molar tooth. So if you see these combination of words in an MCQ, you know it's buccinator. We'll come to that. Okay, so buccinator muscle is very important here with the parotid duct. Moving on to the sensory innervation of the parotid. Okay, so let's calm down. Let's take a break. Let's take a breather before we start the innervations. Um, Starting off with the sensory innervation. Okay, so this is done by the auriculotemporal nerve, which is a branch of the V3, which is the mandibular one, right? So the mandibular nerve is the C and V3, and the auriculotemporal nerve is a branch of that. So it covers the skin over the gland. So this is all auriculotemporal. And then, oh, sorry, no, actually, hold on. The sensory innervation of the parotid gland is auriculotemporal, and the skin over the gland is the great auricular nerve. Okay, so the skin over the gland is the great auricular nerve, and the innervation of the parotid gland is the sensory auriculotemporal nerve. Okay? Now, in parotitis, mumps. So mumps is a highly contagious viral infection of the parotid gland, and swelling of the gland within its tough capsule causes intense pain, which is exacerbated by compression between the mandibular ramus and the mastoid process during chewing. So basically, mumps is very painful for kids, especially when they're chewing. Paresis of the terminal 5 branches is possible because if there's mumps, if there's an infection there, it's going to maybe paralyze the 5 expression muscles. Yeah, 5 nerves that supply the facial expression muscles. And then if this parotitis, if mumps is contracted by an adult, the infection can be more serious. And this may cause orchitis or sterility. Okay, so moving on to this little paragraph. The auriculotemporal nerve also supplies the external acoustic meatus and the TMJ region, which is the temporal mandibular joint, so basically your jaw. So parotid inflammation can produce ear pain as well. So even though the ear itself is normal, so it's just like referred pain, sort of, right? Now for the parasympathetic innervation of the parotid, do not panic. This is very easy. Parasympathetic is just producing saliva. It's secretomotor, right? So what is secretomotor to the parotid gland? It's the glossopharyngeal nerve, so the nerve number 9. So let's start off with this over here, okay? So the preganglionic neuron location is in the inferior salivatory nucleus in the medulla. So you have the brain in the back, somewhere in the medulla. You guys know this better than I do. So you have the medulla, you have the inferior salivatory nucleus. The preganglionic nerve is CN9, so cranial nerve number 9. It's going to enter into the middle ear. It's going to become the tympanic nerve or the Jacobson nerve. Then it's going to leave the tympanic plexus. It's going to become the lesser petrosal nerve. And the site of synapse for this is the otic ganglion. So notice this is all preganglionic, and then it comes to the otic ganglion, right? After the otic ganglion, it becomes postganglionic. So this cranial nerve number 9, it just goes to the otic ganglion. It's like, what do I do now? Okay, how do I get to the parotid gland? It sees that the auriculotemporal nerve, which is a branch of V3, is already going to the parotid gland. So it's like, you know what, let me just go with the auriculotemporal nerve, right? So it just hitchhikes onto V3 and it goes to the parotid gland. Okay, so exam focused questions from the slides. Preganglionic cell body location is in the inferior salivatory nucleus medulla. Postganglionic is in the otic ganglion. Preganglionic pathway is cranial nerve number 9, tympanic plexus, lesser petrosal nerve. And postganglionic pathway, it's like, I need to get to the parotid gland. Can you give me a ride? Calls it the auriculotemporal and goes with the auriculotemporal to the parotid gland. That is how you get saliva in the parotid gland. Frey syndrome. Okay. Let's read this first. Sweating and flushing of skin along the distribution of the auriculotemporal nerve. We just talked about the auriculotemporal nerve. What's going on here, right? So after parotid surgery, abnormal reinnervation leads to sympathetic-like effects in response to parasympathetic stimuli. So instead of salivating, the patient is going to sweat and flush, right? So normally, you have parasympathetic cranial nerve number 9, right? It goes through the otic ganglion, it hitchhikes onto the auriculotemporal nerve, it goes to the parotid gland, right? After surgery, okay, you have surgery of the parotid gland because of any reason, the parasympathetics are going to regenerate, okay? But instead of this cranial nerve number 9, secretomotor, going to the parotid gland to make saliva, you know what it does? It goes to the sweat glands and it goes to the cutaneous blood vessels instead. So the parasympathetic nerves regenerate toward the sweat glands and the cutaneous blood vessels. So when the patient sees food, they're supposed to salivate, right? Parasympathetics are going to make the person salivate when they see food. But in this person with Frey syndrome, the parasympathetics regenerated, instead of the parotid gland, they regenerated onto the sweat gland. So the person starts sweating and they become red because of the blood vessels. So that's basically it. That's sympathetic-like effects. I hope that's very, very clear. Crocodile tear syndrome is very similar to Frey syndrome, except that the parasympathetics regenerate toward the lacrimal gland. So in Frey syndrome, it was toward the sweat glands and toward the blood vessels. In crocodile tears, it goes towards the lacrimal gland. So the person sees the food and then they start crying or salivating. Right? Next, we move on to the sympathetic innervation. Okay, so again, what's the difference between parasympathetic and sympathetic? It's okay to be confused. I still am. Parasympathetic stimulates salivation. Sympathetic decreases salivation. So clinically, if a person is stressed, they're sympathetically activated. So salivation is decreased, they have a dry mouth. Now, how do we go through the pathway? Okay, very simple again. Preganglionic neuron location is intermediolateral cell column lateral horn of T1 in the spinal cord. Okay, so parasympathetic was in the medulla. Sympathetic is in the spinal cord. So the preganglionic fibers enter the sympathetic chain via the white ramus communicans, and it goes up the sympathetic trunk to the superior cervical ganglion. Okay, so whatever is happening, all these white rami are going to the cervical ganglion, and they're going to synapse there. Okay, so once they synapse, it's going to become postganglionic. So postganglionic pathway is toward the external carotid plexus. So the postganglionic fibers are going to travel along the external carotid artery and its branches. And finally, they reach the parotid gland. So the main effect when sympathetic is activated is that you have vasoconstriction and decreased watery salivation. Okay, so you have a dry mouth and vasoconstriction. I hope that's very clear as well. This is just, okay, let's go through this. Okay, so the red one is sympathetic. So this is sympathetic on this side. The blue one is parasympathetic, so it's on this side, right? So let's look at the blue one first, which is parasympathetic. We discussed this first. So we have the medulla oblongata. We have the glossopharyngeal nerve. It's synapsing at the otic ganglion, and then it goes on with the auriculotemporal nerve. It goes up. Okay, so basically that's all you need to know. The sympathetic fibers over here start off from the spinal cord, as you can see, go up, go up to the external carotid artery, and then they go do their job in the parotid gland. Okay. Now we move on to the final section of Dr. Vlad's lectures, which is the blood supply of the face, right? You need to draw these out to understand them properly. Okay, so let's start off from, let's change the color actually to purple. Let's start off with the arch of the aorta. Number 1 is arch of the aorta. Number 2 is brachiocephalic. Number 3 is left common carotid. And number 4 is left subclavian. So we're going to focus on number 3 right now. Number 3 is left common carotid. It goes up, it stops here. Okay, what's over here? This is the superior border of the thyroid cartilage. Okay, so at the superior border of the thyroid cartilage, it's going to divide. So number 5 is the internal carotid. We're not concerned. Number 6 is the external carotid. Okay, and the external carotid is supplying the face, right? So we have 3 anterior groups, 3 posterior groups, and 3 median groups. You don't need to memorize right now. We're going to go through this in detail, but I'm just going to say them. So this is external carotid number 6. Okay, it's going to give 3 anterior branches. So number 7 superior thyroid artery. Number 8, lingual artery. Number 9, look at that, so long. That's facial artery. Okay, and then it goes a little bit up over here, and then it gives off 3 posterior branches. So number 10 is sternocleidomastoid artery. Number 11 up here is posterior auricular artery, and number 12 is the occipital artery. Okay, and then you have the median group. You have this one, number 13, it's going up, superficial temporal artery. And then that gives you 2 branches. So you have the frontal branch, and then you have the parietal branch. And then you have the maxillary artery, which is number 16, which is one of the median ones. So it gives off 2 branches. So you have the middle meningeal artery, you have the inferior alveolar artery, and then the third median group branch is the ascending pharyngeal artery, which is over here. So I just basically yapped. If you're following along, you might have gotten it. If you didn't, that's okay, because we're going to do this in detail. So the anterior group, you have the superior thyroid artery, number 1. Okay, so if you look over here, this is the common carotid, okay? And this is dividing into the external. So this is the external right now. External is going to give rise to this is the superior thyroid artery, okay? That's done. It gives off the superior laryngeal artery. Sorry, it goes along with the superior laryngeal artery, and it supplies the upper larynx, right? Then you have the lingual artery. So if you go up a little bit, external carotid, and then you go left, that's the lingual artery, and supplies the tongue. And then you have the facial artery, you go a bit up, and then you get to the facial artery, so it gives off a tonsillar branch to the palatine tonsil. You need to remember that. Then the posterior ones. Number 1, you have the occipital artery. Okay, so let's go up to external carotid. Okay, go up, 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 up. The first one, this posterior branch, is the occipital artery. Then you have, go up again, then you have the posterior auricular artery. And then you have the sternocleidomastoid artery, which is not shown in this diagram. Okay, then we move on to the median ones. So this is the external carotid, right? This is the first one, ascending pharyngeal artery. And then you keep going up, 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 up. You have the maxillary artery, and you have the superficial temporal artery. So I want you to know that the maxillary artery is a terminal branch of the external carotid, and the superficial temporal artery is also a terminal branch. Remember that, and remember these supply. So the pharyngeal artery supplies the pharynx, the prevertebral muscles, the middle ear, and the cranial meninges. Okay, this is just restructured again. The external carotid artery has 2 branches that we want to focus on here in the slide. You have the facial artery, which is the chief artery of the face. Inferior border of mandible anterior to masseter is pressure point to control facial artery bleeding. So if facial artery is bleeding, and if you want to control the bleeding, you're going to go to the inferior border of the mandible anterior to the masseter, and that is the pressure point where you want to control the bleeding, right? You have the superior and inferior labial artery, so towards the lips. Labial is lips. The angular artery, part of the artery that runs along the nose, the medial angle of the eye. Okay, this is very important. If you look over here, this is the facial artery. Where's the facial artery? This is the facial. Yes, this is the facial artery over here. Okay. It's going to give off the superior labial artery, and then it's going to give off the angular artery and the angular vein. Okay, so this is over here. And then you have a superficial temporal artery, which gives off the transverse facial artery. Okay, so this is a superficial temporal artery, and it's giving off the transverse facial. And then the internal carotid artery, which we said we were not concerned about, but apparently we are now. I wonder why. We have the supraorbital and supratrochlear arteries. Okay, I'll tell you why we're concerned, because we want to talk about the collateral circulation. External carotid and internal carotid and the face, they have collateral circulation. Okay, so the external carotid gives off the facial artery, right? And then that gives off the angular artery. We just talked about this. Internal carotid gives off the ophthalmic artery, and it also then gives off the dorsal, this is dorsal, the dorsal nasal artery. Okay, so those 2 are where the collateral circulation happens. This is very important. You need to know this. Moving on to the venous drainage. Okay, very heavy slide. I should have animated this, low-key. Okay, very easy. Let's focus on the text first. So the pterygoid venous plexus is going to join up and is going to give the maxillary vein. Okay, so as you can look over here, this whole network is the pterygoid venous plexus. Let me change the color to blue. So this is the pterygoid venous plexus. So this area, right? It's all going to join up, as you can see, it's joining up over here. It's giving the maxillary vein. Okay, so that's done. Next, the maxillary vein and the superficial temporal vein are going to join together. So the maxillary vein over here, we just said, is going to join up with the superficial temporal vein, and it's going to give you the retromandibular vein. The retromandibular vein is going to split. Okay, it's going to give the anterior division, it's going to give the posterior division. So the anterior division of the retromandibular vein is going to join with the facial vein. Okay, so this is the facial vein. Okay, it's going to join with the anterior division of the retromandibular vein. It's going to go and it's going to give the internal jugular vein. Okay, the posterior division of the retromandibular and the posterior auricular vein are going to give the external jugular. So very easy way to remember is that the posteriors of the retromandibular are going to give external jugular because posterior division of retro and posterior auricular vein external, and the anterior division of the retro plus the facial vein is going to give the internal jugular. Okay, easy. This is just a restructure again. So the deep system is the internal jugular vein. Okay, so you have the pterygoid venous plexus. It becomes the maxillary vein. Maxillary vein is going to become the retromandibular vein. Okay, and the retromandibular vein is going to go ahead, join up with the facial vein. You're going to get the common facial vein, and then you'll get the internal jugular vein. Okay, so this is a deep system. Superficial system, you have the superficial temporal vein. It's coming from the superficial areas. It's going to go join the retromandibular vein, and then it's going to go join the external jugular vein. So basically what this means to say is that the common ground between the two deep system and their superficial system is the retromandibular vein. So that's what's important, I guess. Okay. Then we move on to more superficial veins. Okay, so the external jugular vein, oh yeah, this is the basically where the external jugular vein is on the muscles. So the external jugular vein begins posterior to the angle of the mandible. So this is the angle of the mandible, it's behind that. And then union of the posterior auricular vein and posterior division of the retromandibular vein. So these two veins are going to join and they're going to give you the external jugular vein, right? So this is over here. The external jugular vein is going down, 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 down. Over here, it's going to pierce the deep fascia and it's going to drain into the internal jugular vein. Okay? These are the anterior jugular veins. So this is number 1, this is number 2, as you can see. And they're both joined by the jugular venous arch. Okay? Easy. Internal jugular vein drains blood from the brain, from the face, and from the neck. Okay, begins the jugular foramen as a direct continuation of the sigmoid dural venous sinus. Descends in the neck, embedded in the carotid sheath. You can see here, a huge thingy here is the carotid sheath, posterior to the sternal end of the clavicle. So this is the clavicle around, like here. So you can see it's around the clavicle. It's going to join with the subclavial vein to form the brachiocephalic vein. So it has dilatations at its superior and inferior ends, and the superior bulb and inferior bulb, they basically contain valves to prevent backflow of blood. So it's just blood going toward the heart. Same thing again. Internal jugular vein is a continuation of the sigmoid dural venous sinuses, the tributaries. So the inferior petrosal sinus, as you can see over here, is going to drain in. This assists in draining the cavernous sinus. You have the facial vein. You can see it's also draining in. You have the pharyngeal veins, pharyngeal venous plexus, again draining. The superior and middle thyroid veins, also tributaries. Okay, and this all goes down at the inferior bulb and valve of the internal jugular vein, and then it goes and goes towards the heart. Okay, so towards the face, we talked about this again. We have the facial vein. Okay, so it begins as the angular vein near the medial angle of the eye and parallels the facial artery, provides the major venous drainage of the face into the internal jugular vein. So facial vein, you recall, was internal jugular vein. Then you have the superficial temporal vein, which superficial face. And then you have the retromandibular vein, which was the common ground for both the internal jugular, the deep system, and the external jugular, the superficial system, right? It's formed by the union of the superficial temporal vein and the pterygoid venous plexus. So, yes. Now, last slide is the dangerous triangle of the face. It starts off from here, the nose, and then it goes up to like the upper lips, right? So why is this dangerous? Okay, you guys can think about that while I explain. Actually, focus with me. The cavernous sinus inside the cranial cavity connects with the facial angular vein through the superior ophthalmic vein and the pterygoid plexus to the deep facial vein and the inferior ophthalmic vein. Okay, what does that mean? What's going on? Let me tell you what's going on. Okay, we're going to take the purple. So this is the cavernous sinus over here, right? With the star. It is supplied by this superior ophthalmic vein over here and the inferior ophthalmic vein over here. The superior ophthalmic vein is coming from the facial vein. Okay, so this is the facial vein. It's going to the superior ophthalmic vein. It's going to the cavernous sinus. The pterygoid venous plexus, this whole plexus over here, is going through the inferior ophthalmic vein to the cavernous sinus. So from the bottom and from the top, everywhere, it's going to the cavernous sinus, right? So the middle third of the face is a danger area because infections there may produce thrombophlebitis. So what is thrombophlebitis? Okay, let me read off the definition. It is an inflamed vein with clot formation. Okay, so if the vein gets inflamed and there's clot formation, you call that thrombophlebitis. And if there's bacterial infection as well, it's called septic thrombophlebitis. For example, what would happen if there was a pimple on your face and you popped it, and there was bacteria in the pimple, and then it went into the facial vein, and then it went to the angular vein, and then that went to the superior ophthalmic vein, and that went to the cavernous sinus. So the pimple reached your brain because there were no valves in the middle to stop the blood going back, right? So that's basically causing the infection to spread from your face or from like the superficial facial artery or whatever to the brain. Okay, and that is why it's called the dangerous triangle. So it's going to lead to meningitis and cavernous sinus thrombosis. Okay, so that's from the facial artery and the angular artery and the superior ophthalmic artery. So that's the order you need to know. Root canal infection. The upper molars may spread by the pterygoid venous plexus. So if you have a molar infection somewhere, a root canal infection, it's going to go upper molars, pterygoid venous plexus, inferior ophthalmic vein, and then towards the cavernous sinus. So you are in danger. Okay. Let's move on to the questions, right? So, number one, a 9-year-old girl suffers from the mumps, causing unilateral inflammation to her right parotid gland, as seen in the photo. The girl is experiencing great pain due to stretched capsule of the parotid gland. Her physician is also concerned about the condition of the structures contained within the gland. Which of the following structures may be directly compressed in this situation? Okay, so you have buccal nerve of V3, you have auriculotemporal nerve, you have the posterior belly of the digastric muscle, you have the external jugular vein, and you have the facial artery. What do we think the answer is? Okay, pause and answer. It's B. Why is it B? Because you have sensory innervation of the parotid gland is why the auriculotemporal nerve, it's inside. Okay. And then we move on to the next question. A 64-year-old male professional angler is diagnosed with a skin melanoma above his right eyebrow after years of excessive sun exposure. His dermatologist removes his cancerous lesion, but the doctor needs to rule out possible metastasis. What group of lymph nodes would his physician first check for possible spread of the cancer? So he has skin cancer. Where is it going? So we just talked about this. Pause and think. The answer is C. Okay, so the parotid lymph nodes receive lymphatic drainage from the lateral part of the anterior scalp, anterior part of the auricle, lateral part of the face, including the upper and lower eyelids. Due to the side of the skin melanoma of the right eyebrow, the physician must check the parotid lymph nodes for spread of cancer. Okay, so just remember these: anterior scalp, anterior part of the auricle, lateral part of the face, upper and lower eyelids. Okay. Next question. A 35-year-old woman comes to her dentist complaining of tenderness and pain in her cheek near the parotid gland, as well as bad breath and a foul-tasting mouth at meal times. A radiopaque fluid is injected into the parotid duct system through cannulation, and this cyalography of the parotid duct confirms calculus, cyalolith. What muscle through which the parotid duct passes is most likely causing the stenosis, where the cyalolith now resides? So we talked about this. It goes and then it pierces what? It pierces the buccinator. The answer is A. You can read that on your own. Okay, so during surgery for a malignant parotid tumor in a 69-year-old woman, the main trunk of the facial nerve is lacerated. Which of the following muscles is paralyzed? So facial nerve, motor to facial expression muscles, is lacerated. Which of the muscles is paralyzed? Masseter, stylopharyngeus, anterior digastric, buccinator, and tensor tympani. Which one is a facial expression muscle? The answer is D. Okay. Move on to the last Hopefully. No, not the last question. Never mind. The dangerous triangle of the face is clinically important because infections in this region may spread to which of the following venous structures? Okay, so internal jugular vein, external jugular vein, retromandibular, cavernous sinus, anterior venous plexus. What area do we want to avoid? Think about it. The answer is D, cavernous sinus. So we don't want the infection going to the cavernous sinus. A 35-year-old woman is hospitalized due to cavernous sinus thrombosis resulting from infection on the face. Which of the following is the most direct route for the spread of infection from the face to the cavernous sinus? Okay, what do we think the answer is? Because we're talking about the face, the facial vein. Is it pterygoid venous plexus? Is it superior ophthalmic vein? Is it these three? The answer is B. So superior ophthalmic vein drains directly into the cavernous sinus, and that is from the facial vein and the angular vein and whatnot. Right? The basilar venous plexus connects to the inferior petrosa sinus. It communicates with the internal vertebral venous plexus. You don't really need to know that. The parietal emissary veins and the frontal venous plexus do not communicate directly with the cavernous sinus. So for A, which was, what was A? Pterygoid venous plexus, it was from the root canal infections, not from facial infections. Okay? And alhamdulillah, that's it for Dr. Bad's lectures. All right, we're back for the fourth lecture, which was the fossa, the temporal, infratemporal, and pterygopalatine. So, bismillah. We have muscles of mastication. Let's look at all the landmarks on the skull. Okay, so number one, you have the ramus of the mandibles. This is number one. Let me use my pen. Okay. So number one is the ramus of the mandible, so this area. Two is the coronoid process. So this is coronoid, and number three is condyle, the head of the mandible. Number four is the articular tubercle, so this little projection here. Number five is the mandibular fossa. So tubercle is the projection, and the fossa is the depression, like it's where the condyle inserts. Number six over here, this is the angle of the mandible, so it's like an angle. Number seven is the body of the mandible. Number eight is the styloid process. Number nine is the mastoid process. Number 10 is the zygomatic arch. Number 11 is the temporal fossa, as you can see here, the four bones. 12 superior inferior temporal lines. This is superior line. This is the inferior temporal line. Number 13, this is the maxilla. So this area is the maxilla. Number 14 is the zygomatic bone, and number 15 is the pterygopalatine fossa. As you can see here, right there, this is the pterygopalatine fossa, this opening. So again, one more time, this is the superlateral view. This is the head, the condylar process. This is the neck. This is the mandibular notch. This is the coronoid process. The lingula is inside. The mandibular foramen is also inside. The mylohyoid line, the submandibular fossa is below the mylohyoid line. The sublingual fossa is above the mylohyoid line. Then you have the alveolar process. This one, the mental protuberance, so basically like the chin protruding outwards. Then you have the mental foramen, which is the hole where the mental artery comes out of. So what happens in a person who is old? The mandible of the edentulous. Number one is loss of teeth leads to bone resorption along maxillary and mandibular alveolar processes. So the teeth are gone. Okay, over here, number one. Number two is bone resorption causes loss of height of body of mandible, leading to apparent shift of the mental foramen superiorly. So you thought that the mental foramen was at the back, but when you become old, because of the loss of bone, the mental foramen shifts forward, apparently. Bone loss also leads to flattening of the angle of the mandible, so this angle just becomes flatter like this. Moving on to the boundaries of the temporal fossa. So what is a temporal fossa, right? It's like this depression in the temple. Anteriorly, you have the frontal process of the zygomatic bone and zygomatic process of the frontal bone. Okay, isn't that the same thing? No, it's not. This is the zygomatic bone. Okay, and this is the frontal process. Okay, so this is the frontal process. This is the frontal bone, and this is the zygomatic process at the top. Superior and posterior, you have the inferior temporal lines on the parietal and frontal bones. So here, this is the superior, and the posterior, you have the superior and inferior temporal lines, okay? Inferiorly, you have the zygomatic arch. So this is the zygomatic arch, this thing, okay? The floor is the pterion. So this colored area is the floor. And the pterion, if you recall, was the area of epidural hemorrhage, where like the middle meningeal artery ruptured, and then it was a very disastrous events. Then you have the roof, the temporal fascia, deep fascia overlying the temporalis muscle. So at the bottom you have the bones, and then on the top you have the fascia overlying. Then the contents. You have the temporalis muscle. Okay, so it attaches over here. Um, it originates over here. The temporal fascia, which is overlying the temporalis muscle, the deep temporal nerves, and the deep temporal arteries. So the deep temporal nerves are part of the V3, which is the mandibular branch of the trigeminal, and they have the deep temporal arteries. So anterior and posterior branches of the maxillary artery from the infratemporal fossa ascend to supply the temporalis muscle. This is the temporalis muscle. It's like shaped like a fan. So origin is the floor of the temporal fossa. It inserts into the apex and medial surface of the coronoid process. So this is the coronoid process, as you can see here. So it's inserting at the apex and the medial surface over here. Um, sorry, apex and medial surface and the anterior border of the ramus. So this is the ramus here, and it's inserting over there. The supply is the deep temporal nerves and the arteries. Elevation is done by the anterior fibers, so anterior ones, and retraction is the posterior fibers. Okay, then we move on down to the infratemporal fossa. So we have the temporal fossa. So below it, we're going to have the infratemporal fossa. So you can see here is a zygomatic arch. So this is the temporal fossa. So below here, this is the infratemporal fossa. So like behind this zygomatic arch. So if you cut out the zygomatic arch in this view, you can see the infratemporal fossa. Let's start off with the roof. So the roof over here is the infratemporal surface of the sphenoid. So this is the sphenoid over here. Okay, this is the roof of the infratemporal fossa. Anteriorly, you have the posterior surface of the maxilla. So you can see this is the maxilla. Okay, and this is the posterior surface of the maxilla, right? And then you have the lateral wall, which is the ramus of the mandible. So laterally, it's low-key cut from here, but this is the lateral wall of the infratemporal fossa. Medially, this yellow thing, what is this? This is the lateral pterygoid plate of the sphenoid bone. And posteriorly, you have the tympanic plate and the styloid process, which is right there. It's the styloid process and the tympanic plate. The superior communicates with the temporal fossa deep to the zygomatic arch. So superiorly, if you go up, it's going to be the temporal fossa. And the inferior is open. And remember that. There is no boundary at the bottom. Now, for the contents of the infratemporal fossa, first of all, you're going to start off with the pterygoid muscles. You have the medial pterygoid muscle and you have the lateral pterygoid muscle. So both have two heads. So for the medial pterygoid muscle, you have the deep head and you have the superficial head. Okay? For the lateral pterygoid, which is this outer one, you have the upper head. This is the upper head. And this is the lower head of the lateral pterygoid. Okay? And both of these attach to the lateral pterygoid plate of the sphenoid bone. Nothing attaches to the medial pterygoid plate. We'll come to that. Okay, what else do we have? We have the maxillary artery, which is, recall, a terminal branch of the external carotid artery. You have the middle meningeal artery, which is a branch of the maxillary artery. You have the inferior alveolar artery, also branch, deep temporal arteries, and then the pterygoid venous plexus, which we just talked about. What about all these nerves? You got to learn all these nerves, unfortunately. So you have the mandibular nerve, inferior alveolar, lingual, buccal, chorda tympani, nerve to mylohyoid, auriculotemporal, and the otic ganglion. Right? This is the posterior view of the infratemporal fossa. You can notice here the middle meningeal artery, the maxillary artery, the inferior alveolar artery, the lateral pterygoid, and the medial pterygoid plate is right there. Okay? So just know that these muscles, the lateral medial pterygoid muscles, lie in the infratemporal fossa. Okay, moving on. What is the clinical significance of the infratemporal fossa? First of all, dental abscesses from the lower third molars can spread inferiorly into the parapharyngeal space. So, infratemporal fossa, below the infratemporal fossa, it can go into the parapharyngeal space. Okay, now infection can then track to the retropharyngeal space, so it's just going through all the spaces and it's going to airway compromise. Now, why is that? What is Ludwig's angina? Ludwig's angina is rapidly spreading cellulitis, okay? This is of the submandibular and the sublingual and the submental glands. So all these subglands, they start to get inflamed and they start poofing up, okay? And this is because of the infected molars, the infected lower molars. So when they start poofing up, the mouth swells from the bottom. And when the mouth swells from the bottom, the tongue is forced backward. If the tongue is forced superior and backward, it's going where? It's going to the trachea, right? So the person cannot breathe because the tongue is choking them and like this whole part is swelling up. And that is basically Ludwig's angina. Then you have tumors of the nasopharynx, which can invade the infratemporal fossa via the pterygomaxillary fissure. We'll come to that. Nerve blocks are performed by injecting to the space at the mandibular foramen. Okay. Yeah, this is just what I said. Rapidly spreading cellulitis. Why dangerous? Because swelling elevates the tongue and floor and airway obstruction. Then you have the pterygopalatine fossa. So, what have we covered so far? We had the temporal fossa. We went down. We had the infratemporal fossa. Now we go a bit deeper. Okay, we go deeper immediately. We have the pterygopalatine fossa. As you can see here, this is the lateral pterygoid plate. This is the posterior border of the maxilla, and here in the middle you have the pterygopalatine fossa. The pterygopalatine fossa is the hole. Okay, it's like the inside. The this opening that you can see is the pterygomaxillary fissure, and then you also have the infraorbital fissures over here. Don't worry about those. And the posterior surface of the maxilla. This is the posterior surface. Okay. Now, what are the borders? Anteriorly, you have the posterior infratemporal surface of the maxilla, which we just talked about. This is the infratemporal surface of the maxilla. This is anterior. Posteriorly, you have the anterior surface of the pterygoid process and the greater wing of the sphenoid. Okay, this is in the back. Medially, you have the perpendicular plate of the palatine bone with the sphenopalatine foramen. So this inside, we said that this was the pterygopalatine fossa, right? So this is the fossa. Now, if you go deeper into the fossa, you come to the sphenopalatine foramen. Okay, so that's medially. Laterally, it communicates with the infratemporal fossa via the pterygomaxillary fissure. Superiorly, you have the orbital process of the palatine bone and inferior surface of the body as sphenoid. And then inferiorly, it narrows to form the greater palatine canal. So that's the inferior part. Okay, so the pterygopalatine fossa is a pathway for perineural spread of nasopharyngeal and oral cavity tumors into the skull base. Remember. Okay, this is what I was talking about. This is a pterygopalatine fossa, allegedly. It is. Okay, and this is the fissure. Like the fissure is like the opening that you can see. Fossa is like inside. And this is a pterygoid process, the lateral plate. Now, if you just twist the skull a bit like that so that you can see inside, this is still the pterygomaxillary fissure, the pterygopalatine fossa, and then inside, if you go inside, there's the sphenopalatine foramen. Okay, that's the actual foramen in there. Okay, now this is just like a 3D diagram of the pterygopalatine fossa. It's an empty space, but this is what we perceive that it looks like. We're starting off with the sphenopalatine foramen. So we said medially, it's the sphenopalatine foramen. So if you go into the skull, it's going through the sphenopalatine foramen, right? And that opens to the nasal cavities. It's like going to the nasal cavity. Focus here. This is the foramen rotundum. This is the pharyngeal canal. This is the pterygoid canal, and this is the whole fissure, right? Going down, you have the greater palatine canal, and you have the lesser palatine canal. Okay. Going forward, you have the infraorbital groove. Now, let's look at some of the nerves, because we have to. Cranial nerve, trigeminal division number 2 is the maxillary nerve, right? The maxillary nerve is going to go through the foramen rotundum. It's going to go in, and it's going to, let's wait for that. Okay, so this is what happens initially. On the other hand, you have the pharyngeal nerve going in, and then you have the greater petrosal nerve, which is coming from cranial nerve number 7, the facial nerve. Okay, it's also going in. It's joined by the deep petrosal nerve from the internal carotid artery. Okay, now these are also all going inside as well. Now this is what we call the moving on, the nerve of the pterygoid canal. Okay, so let's go through this one more time. You have cranial nerve number 2. It's going to give off its own branches. Okay, it's going to give off the zygomatic nerve. It's going to give off the infraorbital nerve, right? This one, greater petrosal nerve and the deep petrosal nerve, they're all going, and they join here to become the nerve of the pterygoid canal, also called Vidian's nerve. They go here, and then they come to this round thing. This is the pterygopalatine ganglion, okay? And this is where this greater petrosal nerve is going to synapse, and it's going to go to the lacrimal gland via the zygomatic nerve, okay? Now let's look at the table. We have fiber type preganglionic parasympathetic. Origin, superior salivary nucleus via the greater petrosal nerve. So we're talking about this. So cranial nerve number 7, greater petrosal nerve, it's going to relay in the pterygopalatine ganglion. Okay, so this facial nerve is going via the greater petrosal nerve. It's going to the pterygopalatine ganglion. Now, as it's over there, it's like, how do I get to the lacrimal gland, right? Then it looks at the zygomatic nerve going to the lacrimal gland. It's like, you know what, let me just hop onto that. So zygomatic nerve is a branch of the V2, but the seventh cranial nerve is going to hitchhike onto zygomatic nerve and go to the lacrimal gland. Okay? And if you remember, this was the case with cranial nerve number 9 in the otic ganglion. It just went up with the auriculotemporal nerve, right? So this is what happens here, but like with a different nerve. Then you have the postganglionic sympathetic, which is this carotid artery plexus over here. So origin is superior cervical ganglion via the deep petrosal nerve. So this is a deep petrosal nerve. It's just going to go there. It's not going to synapse. It's not going to synapse. It's just going to pass through and supply the blood vessels of the nasal mucosa. Okay? And then you have the sensory, which is V2. So this is sensory V2 coming. It's coming from the trigeminal ganglion. It's going to relay in the pterygopalatine ganglion. It's not going to synapse again. It's just going to pass through and go to the nasal cavity, the palate, and the nasopharynx. Okay? So just a little summary of what we've said so far. The cranial nerve number 7 gives off the greater petrosal nerve. It goes to the pterygopalatine. It synapses over there. It hitchhikes onto zygomatic nerve, which is part of V2, and goes to the lacrimal gland. Okay? This is parasympathetic. This is how the lacrimal gland produces tears. The deep petrosal nerve is part of the postganglionic sympathetic. Okay, and it's just going to relay the pterygopalatine ganglion. It's not going to synapse. It's going to go to the blood vessels of the nasal mucosa. Sensory is V2. Okay, this is what it's usually just coming for, because remember that the trigeminal nerve gives all the sensory innervation to the face. So you had the ophthalmic division, you had the maxillary division, and you had the mandibular division. This is for the trigeminal, right? So it's coming V2, trigeminal ganglion, no relay, just passes through and then goes to sensory supply, nasal cavity, the palate, and the nasopharynx. I hope that's very clear. So the clinical application is that the pterygopalatine ganglion is a target for sphenopalatine ganglion block, used in treatment of cluster headaches, trigeminal neuralgia, and post-dural puncture headache. The block can be performed intranasally or via lateral approach through the pterygomaxillary fissure under fluoroscopic guidance. So if you want to go block this ganglion, you either go through the fissure or you just like go intranasally, so top. This is just what I said. If you want me to read through it, I will read through it. So parasympathetic pathway, you have preganglionic parasympathetic fibers originate from superior salivary nucleus of cranial nerve number 7. They travel through the greater petrosal nerve. It joins the deep petrosal nerve to form the nerve of the pterygoid canal. This is called the Vidian nerve. Enters the pterygopalatine ganglion, and here the parasympathetic fibers, only the parasympathetic fibers, synapse. Okay, and then they hitchhike onto V2, and then they go to the lacrimal, nasal, and palatine glands. Sympathetic pathways, superior cervical ganglion, internal carotid plexus, deep petrosal nerve, pass through the ganglion without synapsing and then supply the blood vessels. Sensory fibers, maxillary nerve, just supply the nasal cavity, palate, and nasopharynx. No synapsing here. Okay, this is what I said, summary. So you have nerve of the pterygoid canal, and then you have the parasympathetics going up, hitchhiking the zygomatic nerve, and then hitchhiking the lacrimal nerve, and then going to lacrimal glands. This is just a summary you can read through on your own. Now we move on to the artery branches, the maxillary artery. So we said that the maxillary was a terminal branch of the external carotid, right? So this is the external carotid over here. And this whole thing is the maxillary artery. So we have the first part, we have the second part, and we have the third part. The first part, I want you to remember, middle meningeal artery, inferior alveolar. All of these are important, by the way, but just remember now for recall's sake, middle meningeal and inferior alveolar. Second part, posterior deep temporal, pterygoid, anterior deep temporal, pterygoid, mesenteric, buccinator, so all the muscles, basically. And then you have the third part, you have infraorbital and sphenopalatine and posterior superior alveolar. So I want you to remember these, right? So blood supply to the maxillary and mandibular teeth and gums. So this is all coming from the maxillary artery. So you can see here external carotid artery. It's going to give off the superficial temporal artery You're gonna ignore that one. So number one is the maxillary artery, okay? It's going to give off number 8, which is the inferior alveolar artery. As you can see in this diagram of inferior alveolar artery. The inferior alveolar artery is going to go down into the mandibular canal. It's going to give off the mental artery at the mental foramen. Okay, remember that. Then the maxillary artery goes on, and then it divides. Okay, it divides into the posterior superior alveolar artery, number 5, and then it goes on, and then it divides into it becomes the infraorbital artery. Okay, so number 2 is the infraorbital artery. Infraorbital artery is going to give you the middle superior alveolar artery and the anterior superior alveolar artery. So just again, this is the maxillary artery coming. It gives off the posterior superior alveolar, so PSA. Then it becomes the infraorbital. Infraorbital gives off the MSA and the ASI. Okay, and then the maxillary artery also gives off the sphenopalatine, the pharyngeal, and the artery of the pterygoid canal. That's what's shown on this diagram as well. And this is just a summary. You can read through it on your own. Remember the middle meningeal artery, foramen spinosum, supplies the dura mater. It causes extradural hematoma. We talked about this. Okay, this is again a summary. So the upper maxillary teeth are supplied by the ASA, the MSA, and the PSA. So the superior alveolar artery. So anterior superior alveolar, middle superior alveolar, and posterior superior alveolar. So superiors. The lower mandibular teeth supplied by the inferior alveolar artery, mandibular foramen, mandibular canal, lower teeth, exits as mental artery through the mental foramen, supplies skin of chin plus lower lip. We just talked about this. And then we have the nasal supply. The sphenopalatine artery, which is a terminal branch of the maxillary, it is going to basically go through the sphenopalatine foramen, right? Now, what happens if someone punches you in the face? You're going to get a nosebleed. And the nosebleed is because of this sphenopalatine artery rupturing. Finally, we move on to the muscles of mastication. Masseter, medial pterygoid, temporalis, and lateral pterygoid. 4 primary ones. So mom makes tasty lasagna. If we're talking about depressing the mandible, that means this is your mandible. If you want to depress it, you open your jaw. If you want to elevate it, you close your jaw, right? So open jaw means depressing mandible and closing jaw means elevating mandible. Let's start off with mom. So the masseter originates at the zygomatic arch. So you can see here, this is a zygomatic arch. It originates here. It goes down and then it inserts into the lateral surface of the ramus of mandible. Okay, so somewhere like here, and then it goes, inserts here. So the innervation is the masseteric nerve from the anterior trunk of the mandibular nerves. That's V3. Function is elevation of the mandible. Makes is medial pterygoid. So we have the deep head and then we have the superficial head. You can see them in the back. So the deep head is going to the medial surface of lateral plate of pterygoid process and pyramidal process of palatal bone. So basically the deep head is going to originate from the medial surface of the lateral pterygoid process. I want you to focus here on the sphenoid bone. The medial pterygoid plate is useless. It doesn't have any of the pterygoid muscles attaching. The lateral plate is where both the muscles attach. So on the medial side of the lateral pterygoid plate, you have the medial pterygoid muscle attaching. Okay. And then they insert into the medial surface of the mandible near the angle. The nerve to medial pterygoid from the mandibular nerve, again, V3. So its job is to elevate and side-to-side movements of the mandible. Moving on to temporalis, tasty. So it starts off from the bone of the temporal fossa and temporal fascia, so over here. And then it inserts into the coronoid process of the mandible and the anterior margin of the ramus. Okay, so anterior coronoid, anterior ramus, almost to the last molar. Now, this is supplied by the deep temporal nerves from the anterior trunk of the mandibular nerve, again, V3, elevation and retraction of the mandible. Now we move on to the most interesting muscle, which is lasagna, lateral pterygoid. This is the only primary muscle that lowers the mandible, that depresses the mandible. All the other 3 are going to elevate the mandible. So, what is this muscle? This lateral pterygoid. So the upper head originates from the roof of the infratemporal fossa, so over here, and the lower head originates from the lateral surface to the lateral plate of the pterygoid process, so over here. And they're both going to insert in the capsule of the temporomandibular joints, so in the capsule of the joints. And the nerve here is V3 from the buccal branch. So the job of the lateral pterygoid is to protrude and side-to-side movements of the mandible. Just read through this. Upper head is associated with the articular disc and the joint capsule. It helps stabilize and control the disc, especially during closing and clenching. So the job of the upper head is stabilizing and controlling the disc. And the lower head attaches to the neck of the mandibular condyle. Its main action is pulling the condyle forward. So it opens and protrudes the jaw. This is just the lateral view of the skull. So you have the capsule and interarticular discs, this black arrow over here, and the blue arrow is the lateral pterygoid muscle attaching to the TMJ capsule and the interarticular disc. This is a summary. Now, for the temporomandibular joints, the TMJ, everyone's been talking about the TMJ. Okay, so this is a temporal fossa and this is a temporal bone. Okay, now recall that your jaw, it inserts on both sides, right? Both sides of their face. It's a bilateral joint. It articulates, the articular surfaces are covered by fibrocartilage, not hyaline cartilage, because fibrocartilage is stronger, and when you're chewing, there's a lot of force involved. It contains intra-articular fibrocartilaginous discs dividing the joint's cavity into two separate compartments. It is capable of both rotation, hinge movement, and translation, gliding movement. So rotates and translates. The articular tubercle, not the mandibular fossa, is a primary load-bearing surface. Let's see what that means. Okay. Uh, we have to know the ligaments of the temporomandibular joint. So the first one is the joint's capsule itself. Okay, it attaches to the margins of the mandibular fossa and articular tubercle above and to the neck of the condyle below. It is lined by the synovial membrane, which secretes the synovial fluid. Then you have the temporomandibular ligaments over here. Now this attaches from the articular tubercle over here to the neck of the condyle. Okay, over here. The function is it limits posterior displacement and excessive opening. So if you want to open your mouth, you can't open it forever. That's because you have the temporomandibular ligaments. Then you have the sphenomandibular ligaments. Over here you can see it goes from the sphenoid to the mandible. Then you have the stylomandibular ligaments, styloid process. So this is the styloid process. It goes to the angle and the posterior border of the ramus. This limits excessive protrusion. The articular disc of the temporomandibular joints. You can see here, this is the articular disc in the middle. It basically divides this the joint cavity into two, right? So you have the upper compartments here, and this is between the disc and the temporal bone, and this allows gliding and translation movement. So the upper compartments is translation. The lower compartment is between the disc and the mandibular condyle. It allows rotation. So rotation occurs here at the condyle, and translation is at the top. Okay? So the interarticular disc divides the TMJ cavity into superior and inferior compartments during opening of the mouth, depression of the mandible, rotation occurs in the inferior compartment, followed by translation. So rotation first, translation second. The lateral pterygoids pull the mandible forward, protract, and down depress, causing it to rotate and slide. So this is opening the mouth. The medial pterygoids, temporalis and masseter, pull the mandible up, elevation, and backwards, retraction, causing the mouth to close. Okay, so this is neutral position. This is the mandibular condyle rotating under the disc. So you open your mouth a little bit, the mandibular condyle is going to rotate a little bit. So this is rotation, first step, right? Second step, you can see here the condyle moved from the mandibular fossa to the articular tubercle. This is called translation, second step of chewing. Okay, the accessory mastication muscles, you need to know digastric, mylohyoid, stylohyoid, and genohyoid. Mylohyoid is here. It originates from the line of the mandible over here. Okay, and it inserts into the median raphe and the hyoid bone. Innervation is mylohyoid, nerve to mylohyoid, which is V3 again. The action is elevates floor of the mouth, depresses mandible. So just want you to focus on the action of all the accessory mastication muscles. They're all depressing. So you can see here, mylohyoid is depressing. Accessory mastication muscles, digastric, is also depressing the mandible. Genohyoid is also depressing the mandible. Okay? Right. So then we move on to digastric. So the anterior belly is supplied by the mylohyoid, and the digastric posterior belly is supplied by the facial nerve. Very important to know this. Genohyoid is, look here, sebum fibers via cranial nerve, what is that, 12? Yeah, 12. So posterior belly of digastric and the genohyoid muscle are not supplied by V3. They're supplied by different fibers. I need to know what those fibers are. So, muscles of mastication, summary, the lateral pterygoid, medial pterygoid, and temporalis are within the infratemporal fossa. The masseter is on the side of the face. All of these are supplied by V3, trigeminal nerve. The accessory muscles of the digastric, anterior belly, it's V3, but posterior belly is facial nerve. Mylohyoid is again V3, but genohyoid is fibers from C1. Summary, opening the mouth, you have the lateral pterygoid depressing, and all the accessory muscles are going to open the mouth. Closing, you have masseter, the medial pterygoid and the temporalis closing, and then at the end of the closing stroke, you have the power stroke. The power stroke is like, if you've seen animals eat, they move their mouth weirdly. Okay, it's very obvious in animals. Like it's like an elliptical. So it's like, I'm not gonna do it, but it's elliptical. So the mandible moves forwards, downwards, and slightly lateral. So it's like a chewing sort of motion, and this creates shearing forces between the upper and lower teeth. The temporomandibular joint is supplied by the sensory nerve, which is auriculotemporal nerve. So if you have pain in your joints, if you have a joint disorder, it can go up to the ear. So like the pain can go to the ear because this is referred pain, because the auriculotemporal nerve also supplies the ear. The main arteries supplying the temporomandibular joint are the superficial temporal artery, the maxillary artery branches, and the mesenteric artery. It's in the name. Summary: you have the temporal fossa, infratemporal fossa, and pterygopalatine fossa. Summary: all the muscles of mastication. You can read through these on your own. And then you have the temporomandibular joint. So this is synovial, condylar, fibrocartilage. Upper compartment is gliding, lower compartment is rotation. Okay? Primary ligament is this one. Primary innervation is this one. Primary supply is superficial temporal artery and the maxillary artery branches. And then this is a bilateral joints. And these are the common disorders that can occur. Now I move on to the final part of this lecture, clinical scenarios. Number 1. Trismus after third molar extraction. A 22-year-old dental student presents to the emergency department with severe difficulty opening her mouth, trismus, following extraction of her lower right wisdom tooth 2 days ago. She had a temperature of 38.5, high, swelling in the right cheek, and severe pain when attempting to open her mouth. She can't open her mouth. So, which muscles of mastication are most likely in spasm? Through which anatomical space would a dental abscess form from the lower third molar spread? What is the most dangerous direction of spread? And what block would you provide? Okay? So let's read. The medial and lateral pterygoid muscles, along with the masseter and reflex spasm due to adjacent infection. The infection is likely spread from the tooth socket into the infratemporal fossa via the pterygomandibular space. The most dangerous direction of spread is inferiorly because the infratemporal fossa has no floor. The infection can track into the parapharyngeal and then to the retropharyngeal. We just talked about Ludwig's angina. It's going to cause swelling, and then the tongue moves backward. Person cannot breathe. So an inferior alveolar nerve block at the mandibular foramen would anesthetize the lower teeth. Anterior dislocation of the mandible. 35-year-old man attends the emergency department after dental procedure. He is unable to close his mouth. His jaw is protruding forward, and he is in significant distress. So it's just it's like it's open and it's protruding forward. He doesn't know what to do. He doesn't know how to close his jaw. So the emergency physician notes bilateral preocular hollowing. So in front of the ear, there's hollowing. Absence of normal condyle prominence. What has happened? Why cannot they close their mouth? And how would you reduce the dislocation? So this is bilateral anterior dislocation of the mandible. Both condyles have moved anteriorly past the articular tubercle onto the preglenoid plate. So basically, remember how the articular tubercle was where it slides, right? It was translation movement. It translated too far, so it cannot go back now. The condyles cannot return to the mandibular fossa because the articular tubercle acts as a mechanical block. Bilateral preocular hollowing occurs because the condyles are no longer in the mandibular fossa. So the fossa is empty, so that's why you can feel it hollow. So how do you reduce? This is the Hippocratic method. Under sedation to relax muscles, place padded thumbs on the lower molar teeth. Apply firm downward pressure to disengage the condyles from the articular tubercle. Then just basically just do like a bunch of manual maneuvers. Okay. Clinical scenario number 3. 28-year-old woman presents with a 6-month history of right-sided facial pain, clicking of the jaw and chewing, intermittent jaw locking, and pain referred to the right ear. She reports grinding her teeth at night. Examination reveals tenderness over the right TMJ and limited mouth opening of 28 millimeters. What is the likely diagnosis? Anatomical structure. Why does she have referred pain to the ear? And what are the treatment options? This is TMJ internal derangement. The articular disc has likely been displaced anteriorly. And this is causing pain in the ear because of auriculotemporal nerve. Okay. Last scenario, Frey syndrome. 45-year-old man underwent a right parodectomy for a parotid gland tumor 6 months ago, presents with an unusual complaint. Every time he eats, the skin over his right cheek and periocular region sweats profusely and becomes flushed. Flushed meaning red. What is this condition called? Which nerve is responsible? What is the anatomical mechanism? So this is Frey syndrome, or auriculotemporal nerve syndrome. So during the parodectomy, the auriculotemporal nerve, which carries the postganglionic parasympathetic fibers, may be damaged. So during healing, instead of the parasympathetic fibers going to the parotid gland, they go to the sweat glands, and they go to the blood vessels. So when the patient wants to eat, instead of salivating, they start flushing and sweating. And that's it. The treatment is Botox. And we are going to the question. This 59-year-old man with a herpes zoster infection with a mandibular division of the trigeminal nerve complains of weakness when opening his mouth. A comprehensive evaluation reveals that his problems are due to difficulty protruding the mandible, and when protrusion is accomplished, the mandible deviates to the left side, as seen in the figure. So he's having difficulty protruding the mandible, and it's deviating to the left side. If you recall, the side-to-side movement was with the pterygoid muscles, and protrusion was lateral pterygoid, so that is B. Okay. All right, so we're back for the last lecture. Let's move on. Bismillah. So we start off with the trigeminal nerve. So the trigeminal nerve has 3 divisions. We have V1, we have V2, and we have V3. Okay, so V1 is the ophthalmic nerve, V2 is the maxillary nerve, and V3 is the mandibular nerve. We've come across these multiple times in the past hour. And we're just going to go see how this trigeminal nerve actually splits and courses through the face. So V1 supplies the upper eyelid, the forehead, and anterior scalp up to the vertex, and then the dorsum or tip of the nose. So you can see upper eyelid, dorsum, tip of the nose, and the anterior scalp. V2 over here supplies the lower eyelid, the lateral side of the nose, the cheek, and the upper lip, and the zygomatic prominence. V3 supplies the lower lip, the chin, the jaw mandibular region, and the temporal region over here by the auriculotemporal nerve. So this is just to orient you again. Over here, this is superior orbital fissure. It transmits cranial nerves number 3, 4, V1, and 6. Rotundum is V2, and ovale is V3. Okay, so trigeminal ganglion, trigeminal nerve. This is OSPI stuff, but for the sake of completion, I've added this. So we have V1, V2, and V3. Supraorbital fissure, rotundum, ovale. Right. So we want to know all the ganglia that are associated with the trigeminal nerve. They don't contribute to the trigeminal nerve, not functionally at least, but they are physically in close proximity to the trigeminal nerve. So let's start out with the ciliary ganglion. This attaches to the branch of the ophthalmic, which is V1. So you can see over here, the ciliary ganglion is attaching to the nasociliary nerve. So the nasociliary nerve is basically a part of trigeminal. The ciliary ganglion is not. The pterygopalatine ganglion attaches to the maxillary nerve over here in the pterygopalatine fossa. It is functionally related to the facial nerve, if you recall hitchhiking, the zygomatic nerve going to lacrimal glands. And then you have the otic ganglion attached to the auriculotemporal nerve, which is a branch of V3. It is located in the infratemporal fossa, functionally related to the glossopharyngeal nerve, if you remember the parasympathetics of the parotid gland. Then we have the submandibular ganglion, which is attached to the lingual nerve, which is a branch of V3. It is located in the submandibular fossa and is functionally related to the facial nerve, cranial nerve number 7. Okay, this is a summary. Ciliary ganglion, functionally related to CN3, pterygopalatine 7, submandibular 7, and otic 9. And then physically in proximity with these nerves, and this is what they supply, so you need to know all of this. So we have V1, the ophthalmic nerve. It is purely sensory. So the frontal, sphenoidal, ethmoidal, paranasal air sinuses. So you have the frontal, ethmoidal, and sphenoid supplied by the ophthalmic nerve. The general sensation to the nasal cavity, the cornea, the conjunctiva, the upper eyelid, the side, and the tip of the nose, all supplied by the ophthalmic nerve. And then it lodges the ciliary ganglion, which is a parasympathetic for oculomotor. The ophthalmic nerve has three branches that you need to know. You have the frontal branch, you have the nasociliary branch, and they have the lacrimal branch. Okay? Let's start off with the lacrimal nerve because it is the most lateral in the orbits. It supplies the lacrimal glands. Then you have the frontal nerve, which is on the roof of the orbits, so it's above the eyeball. And it goes up, it courses above the eyeball, and then at the supraorbital foramen, at the notch, it's going to divide. It's going to give you the supraorbital nerve and the supratrochlear nerve. Okay? Then you move on to the nasociliary nerve. This is the third one. This is the longest one. It goes through the superior orbital fissure. So V1 is going to the superior orbital fissure. It's going and it's dividing to the nasociliary nerve. This passes below the optic nerve towards the medial wall of the orbit. So it's going like this. This is the eyeball. How do I explain this? This is the eyeball. And this is the optic nerve over here. Okay, like this. So the nasociliary nerve is going through the superior orbital fissure. It's going to go and then it's going to go under the optic nerve and then it's going to go to the medial side of the orbit. So in the medial side, you're going to find the ciliary ganglion, you're going to find the posterior ethmoidal and anterior ethmoidal nerves, the nasal branches, and then the infratrochlear nerve. This is a schematic diagram. So this is a trigeminal ganglion, they have superior orbital fissure. So you have the frontal nerve, you have the lacrimal nerve, you have the nasociliary nerve. The lacrimal nerve is going to give you supply to the lacrimal glands. And then the frontal nerve, supratrochlear, which is central forehead and the upper eyelid, supraorbital, so forehead above the orbit and the upper eyelid. Nasociliary is going to give you the posterior ethmoidal nerve, which is the posterior ethmoidal air cell supply, the sphenoid supply, and the frontal sinus. Then you have the anterior ethmoidal air cells and the superior anterior nasal cavity. So all of these are supplied by the anterior ethmoidal nerve. The infratrochlear nerve is going to supply the upper nose, the medial eyelid, the lacrimal canaliculi. Okay, so over here, just read through this. Posterior ethmoidal nerve through the posterior ethmoidal canal is going to supply ethmoidal air cells and the sphenoidal sinus. Anterior ethmoidal nerve is going to enter the anterior cranial fossa, pass through the cribriform plate into the nose, supply the anterior nasal cavity, exit as external nasal nerve, and then supply the tip and central part of the nose. Okay, so look. This is the frontal nerve. It passes above the eyeball. The lacrimal nerve, it's on the lateral wall, if you recall. And then the optic nerve is central. So this is the big, massive thingy. This is the optic nerve. And the nasociliary is passing below it. So this is the nasociliary. So the optic nerve, again, is central. Nasociliary is below it. And then you can see here that this is a long ciliary branch of the nasociliary. It goes directly into the eyeball. And these are the ethmoidal branches of the nasociliary. So over here, it's like towards medially. Okay, now the supraorbital and supratrochlear branches are given off by the frontal nerve, and this is what they supply, and the infratrochlear nerve is given off by the nasociliary, and it supplies the skin and conjunctiva near the medial corner of the eyes over here. Next, we move on to V2, maxillary nerve. This is again purely sensory. It supplies the maxillary air sinus. And then general sensation to the nasal cavity, lower eyelid, skin of cheek, upper lip. So you can see here, so this is the lower eyelid, the skin of the cheek, the upper lip. And then it lodges the pterygopalatine ganglion for a parasympathetic for cranial nerve number 7 in the pterygopalatine fossa. Okay, so ooh, it's a lot of work to do. Let's do that. Okay. All right, so this is V2. I wish I had a writing pad. Okay, this is V2. Can someone tell me what this is? This is foramen rotundum, okay? And this V2 goes through the foramen rotundum and it enters the pterygopalatine fossa. In the pterygopalatine fossa, it's going to give off these two ganglionic branches, which is going to go join up with the pterygopalatine ganglion, and then from the bottom you have the greater and lesser palatine nerves. This over here, this is the posterior superior alveolar nerve, which is going to supply the teeth at the top. And then over here, you can see this one. This is the zygomatic nerve. Okay, if you recall, what was hitchhiking on zygomatic nerve? It was the parasympathetics to the lacrimal glands. Cranial nerve number 7. Okay, So this nerve goes on, V2 is going, 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 and then it enters through the inferior orbital fissure. Okay, this is inferior orbital fissure. And then in this canal, this is the inferior orbital canal, is going to continue as the inferior orbital nerve. It's going to exit at the inferior orbital foramen, and then it's going to give the palpebral branch, the nasal branch, and the superior labial branch. Okay. One thing I just want to add in is that the inferior orbital nerve over here in this canal is going to give off the MSA and the ASA as well. Okay, so let's look at this with a better diagram. Okay, so we have V2. This is V2. This is foramen rotundum. Okay, now we're in the pterygopalatine space here. Okay, and this is the maxillary nerve. We're gonna get a pharyngeal branch, that's okay. This is the sphenopalatine ganglion. We're also gonna get a nasal branch, we're gonna get a lesser palatine nerve and the greater palatine nerve. So the lesser palatine supplies the soft palate, and the greater palatine supplies the hard palate. Okay. And then we're also going to get the zygomatic nerve over here, and this is going to carry sensory to the zygomatic prominence, the cheek prominence, and also the parasympathetics from cranial nerve number 7 to the lacrimal gland. Okay, then we have the infraorbital nerve after it enters through this inferior orbital fissure. So this is the infraorbital nerve. It's going to give off the MSA and the ASA. Okay, so you have the middle superior alveolar and you have the anterior superior alveolar, right? And then it goes on, it goes on, it goes on, it goes on, it goes on. It exits through the infraorbital foramen. It gives off the palpebral branches, the nasal branches, and the superior labial branches. Okay, I hope that's clear. So one more time. This is V2. V2 becomes maxillary nerve. Maxillary nerve is in the pterygopalatine fossa, pterygopalatine ganglion, and then sphenopalatine ganglion, nasal branch, lesser and greater palatine nerves. And then you have the PSA, also the posterior superior alveolar nerve, and the zygomatic nerve that goes on with the parasympathetics of cranial nerve number 7. After it enters through the inferior orbital fissure, it becomes the infraorbital nerve, which gives off the MSA and the ASA. And after that, it exits through the infraorbital foramen, gives off the palpebral branches, nasal branches, and superior labial branches. Very easy. Okay, this is the maxillary nerve in the pterygopalatine fossa. This is the PSA, the posterior superior alveolar nerves. And then these, okay, I added these for the sake of completion. OSCE will be more detailed. So over here, you can see that when the infraorbital nerve exits through the infraorbital foramen, it gives off the palpebral upward, nasal towards the nose, and superior labial nerves. And you also have the dental and gingival branches, the MSA and the ASA, given off by the inferior orbital nerve. Okay, these are the palatine nerves, the greater and the lesser, which are shown over here. So this is the greater palatine, it goes towards the hard palate, and the lesser palatine goes towards the soft palate. Okay. Then we move on to the mandibular nerve. This is a mixed nerve. It is sensory and motor. It is the largest branch of the trigeminal nerve, right? It lodges the submandibular, which is the cranial nerve number 7, and the otic cranial nerve number 9 ganglia, parasympathetics. So for the sensory functions, we have the lower lip, you can see here lower lip, the mandibular teeth and gums via the inferior alveolar nerve, the anterior 2/3 of the tongue, which is general sensation, via the lingual nerve, and the anterior 2/3 of the tongue is taste via the chorda tympani. Okay. Motor functions. So all the muscles of mastication are supplied by the mandibular nerve, which is the third branch of the trigeminal nerve. Okay, so you have masseter, temporalis, medial and lateral pterygoids, plus the mylohyoid and anterior belly digastric. Mom makes tasty lasagna. Also the tensor tympani and the tensor villi palatini muscles. V3 also carries proprioceptive information from muscles of mastication to brainstem about the force of the bite. So did I bite too hard? Did I bite someone's finger off? Something like that. Okay, so a lot going on here. This is the main trunk. Okay, so the main trunk goes through the foramen ovale, okay, which is V3. V3 goes to foramen ovale. It immediately gives off 3 branches. So you have the medial pterygoid nerve, nerve to tensor tympani, and tensor villi palatini. So these are direct branches motor to these muscles. Okay, then it gives off the anterior division and the posterior division. So look over here. You have the anterior, which is mainly motor, and posterior division, which is mainly sensory. Okay? So let's look at the anterior division over here. This is motor predominant. Deep temporal nerve to the temporalis muscle, nerve to the lateral pterygoid, mesenteric nerve, and the buccal nerve. Notice how it says mainly motor, okay, and mainly sensory. So in this anterior division, which is motor predominant, it's predominant. There's still one sensory exception, which is the buccal nerve. It supplies the skin and the buccal mucosa, okay? Then we have the posterior, which is mainly sensory. We have auriculotemporal nerve, we have the lingual nerve, inferior alveolar nerve, and the nerve to mylohyoid and the anterior belly of digastric. Okay, so this last nerve is motor. So it's mainly sensory. Yes, posterior division is mainly sensory, but the last one is motor branch. Okay, just pause and memorize. Okay. Just want to go through this diagram once. So if you look here, this is the lingual nerve. So follow the pointer. So this is the lingual nerve. It is going down, 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 down. And then you have the inferior alveolar, which is below the lingual nerve. So this is the inferior alveolar, and it gives off a nerve to the mylohyoid. Okay? Now, this is the foramen ovale. It's massive. You're going to memorize it just because of how massive it is. And then this is the mandibular nerve. And recall I said that it gives off three branches immediately, right? Those three branches were pterygoid, medial pterygoid, tensor tympani, and tensor veli, right? So these are the three branches. Now, if you see in this cadaveric head, the lingual nerve is anterior, the inferior alveolar nerve is posterior. The auricular nerve is looping upward, like that. And this nerve over here is the buccal nerve. This is sensory. It is part of the anterior division, yes, but it is sensory, and you can see it over here. Okay, so you have the branches to the tensors, then you have the buccal nerve over here. So whenever you see buccal nerve is most interior. So this is the anterior side, right? And then you have the auriculotemporal nerve, it's going to carve upward. Inferior alveolar nerve is in the back, so this is posterior, and lingual nerve is in the front, so this is alveolar. And this long one over here is the buccal. So I guess if you want to learn how do I erase this actually? Hold on, you just rephrase this. Okay. If you want to know what is anterior, you look for the buccal nerve, which is right there, and then you'll find the lingual nerve, and behind it you'll find the inferior alveolar, and then behind that you'll find the auriculotemporal going upward. Okay, again added for the sake of completion, but this is nerve to mylohyoid right here. Okay, and then this is a branch of the inferior alveolar nerve before entering the mandible. So this is the mandible. So before entering the mandible, this is the inferior alveolar nerve. This is the nerve to mylohyoid. Okay, it gives off to the mylohyoid muscle and the anterior belly of the digastric. This is the chorda tympani. Okay, moving on. Okay, so again, lingual nerve to the fronts, and then inferior alveolar nerve to the back. Nerve to mylohyoid is given just before the inferior alveolar nerve enters the mandible. The chorda tympani it's going back like that, and the auriculotemporal nerve is curving upward like this. Okay? Again, lingual nerve over here, auriculotemporal nerve curving upward like that. This is the chorda tympani going that way, and this is submandibular ganglia. Okay, this is a summary. Don't worry, it's just what I said, basically, right? So you have the anterior division, primarily motor with one main sensory branch. So mesenteric, deep temporal, lateral medial pterygoid nerves, they're all motor. Buccal nerve is sensory. Posterior division is all primary sensory, so auriculotemporal, lingual, inferior alveolar, all sensory, and then mylohyoid at the end, which gives off to the mylohyoid. Anterior belly of digastric is motor. Moving on to the last nerve, which is facial nerve, cranial nerve number 7. So this is sensory, motor, and parasympathetic. There's a lot going on there. So motor to a motor car by Zanzibar. Okay? So also supplies the sapedius, posterior belly digastric, and the stylohyoid muscle. Sensory is taste to the anterior 2/3 of the tongue via the chorda tympani, and some sensory scan of the ear, don't worry about that. Parasympathetic is the lacrimal gland, why the pterygopalatine ganglion, remember, hitchhiking, remember, the submandibular and sublingual salivary glands, and then if you get damage in any way, you get Bell's palsy. And patient may also lose taste, salivation, depends on where the lesion is. So, oh, okay. This is the facial nerve proper, right? This is the internal acoustic meatus. It's going into the ear. This is a stylomastoid foramen. This is where it's exiting the skull and it's going towards like the parotid gland, right? This is the facial nerve proper in the canal. Okay, so let's look at what canal this is. Okay. Before we look at what canal this is, I want you to know that between the stylomastoid foramen, where it exits the skull, and between the parotid gland, the facial nerve gives off the posterior auricular nerve, which supplies the posterior auricularis and occipitalis, and the nerve to the posterior belly of the digaster. Okay, and then it goes to the parotid glands. Now, before the stylomastoid foramen and after the internal acoustic meatus, what happens? This happens. Whoa, what's going on here? So this is the facial nerve, okay? To orient you, this is the facial nerve. It enters through the internal acoustic meatus. This is the petrous bone, okay? It's going in, it's going to the middle ear. This is the middle ear over here, okay? And then it has the mastoid segment and it's the stylomastoid foramen. So we want to go from internal acoustic meatus to stylomastoid foramen. This is like the entirety of the ear inside. So this is the medial part of the facial nerve. It's in the petrous bone. And then from this area to the stylomastoid foramen and then onward, this is the facial nerve. It's the facial canal part. Okay? So the facial nerve enters, it goes, it goes, it goes. This is the vestibule, and then this is the middle ear. So it goes to the middle ear, and then it forms the external genu of the facial nerve, right? So this is the facial nerve going. This is the labyrinth segments. Then it enters the middle ear. This is the middle ear cavity. So this whole thing is the middle ear, right? And this in middle ear cavity, this facial nerve is going to take a sharp turn like this. It's like a right angle turn. And that is called the external genu of the facial nerve. Okay, and then this external genu, which is a sharp turn, is going to thicken. It's going to form the geniculate ganglion. And from the geniculate ganglion, we're going to move on towards the mastoid segment, and then we're going to exit to the stylomastoid foramen. Okay, I hope that's really, really clear. So inside the middle ear, all right, so this is the middle ear. So inside the middle ear, you have two branches. You have the nerve to the stapedius, which supplies the stapedius muscle, prevents excessive vibration of stapes at oval window. Damage would lead to hyperacusis. The greater petrosal nerve is also given off at the genu, which is a sharp turn. It carries parasympathetic fibers, exits the petrous horn through the foramen lacerum, reaches the pterygopalatine ganglion, and then it supplies the lacrimal gland and nasal glands. We talked about this. Okay? Then we have the chorda tympani. Why is it called chorda tympani? In mathematics, you have a circle, okay? If a line goes straight to the middle, it's called the diameter. If it goes like towards this part, this is called a chord. So this is a tympanic membrane, and this chorda tympani nerve is going to pass here. This is like the chorda tympani, right? So it goes from the internal acoustic meatus to the petrotympanic fissure. It passes through the tympanic membrane, and then over here, it's going to hitchhike again on the lingual nerve, which is V3, and then it will go to the taste, the anterior two-thirds of the tongue. Okay, so the facial nerve inside the facial canal, which is in the mastoid segments, it's going to give off the chorda tympani. Okay, it's going to pass through the middle ear cavity between the malleus and the incus. It's going to exit the skull via the petrotympanic fissure. It's going to enter the infratemporal fossa and it's going to join the lingual nerve and it's going to go to the tongue. So the chorda tympani has two functions that you need to know: taste, the anterior two-thirds of the tongue, and salivation, so the submandibular and sublingual glands. So if you cut off the chorda tympani, you're not going to be able to taste in the anterior two-thirds, and salivation from the submandibular and sublingual glands is going to be gone. And if you recall, submandibular was 70% of salivation, so you're basically cooked. Right? Then we have the greater petrosal nerve. We talked about this one, but just to recap, it goes from the internal acoustic meatus. This is the greater petrosal nerve, and then it exits. And then it gives off the palatine nerves and the zygomatic nerve up to lacrimal gland. This was in the pterygopalatine fossa. Right? If you recall the pterygopalatine fossa, the preganglionic parasympathetic, this was over here, superior salivatory nucleus via the greater petrosal nerve. It's going to relay in the pterygopalatine ganglion, and then it's going to go to the lacrimal glands, hitchhiking on the zygomatic nerve, which is part of V2. Right. Now we just look at the cadaveric dissection. Okay, so this is the internal acoustic meatus. This is cranial nerve number 7, right there. So it arises at the junction of the pons and the medulla. So you can see here, this is the medulla and this is the pons, and it's arising at the junction. It enters the internal acoustic meatus. So this is it's arising from here. It's going to the internal acoustic meatus. It travels within the petrous temporal bone, runs over the facial canal, and then has the geno, the bend, and then it runs posteriorly along the middle ear cavity, descends vertically downward. We talked about this. So just and out, stylomastoid foramen. So after the exit, it enters the parotid gland. Okay, and this is where it's to motor car by Zanzibar, right? Again, so this is just a bunch of pictures. We'll go through in depth in OSPE, but you have the nerve stapedius in the middle ear. You also have the genu in the middle ear, the sharp turn, and the chorda tympani nerve, which is given off in the mastoid canal. To motor car by Zanzibar. You need to learn this picture. Okay, so this is the 5 branches to motor car by Zanzibar, as you can see, the branches. Yeah, that's pretty much it. This is where it's showing you where the nerves are going. This is the first one, and then this is the second one, third one, the fourth. Right? So this is just a reminder of the hitchhiking. Number 1 is the glossopharyngeal nerve. Okay. It's going, it's going, it's going, it's going, it's going. Where is it going? It's going to become the lesser petrosal nerve, and then it's going to the otic ganglion, and then it's going to the auriculotemporal nerve, and it's going to the parotid gland. Okay. And then you have the facial nerve over here. It has the chorda tympani, gives off the chorda tympani. The chorda tympani goes on and hitchhikes onto the lingual nerve, and then goes to supply the submandibular ganglion. Okay. This is a summary that you should know. So the temporal branch of the tomotor carba Zanzibar supplies the frontalis, the corrugator supersi, the orbicularis oculi of the frontalis, so the vertical wrinkles, the transverse wrinkles, and the eye muscle. The zygomatic branch supplies the zygomatics major, the smiling muscle. The buccal is the buccinator orbicularis oris, so all the mouth muscles, and the nasalis. The marginal mandibular, so the depressor labii, so frowning, depressor anguli oris, and the mentalis, and the cervical is platysma. Okay? And time for questions. So, a young girl complains of dryness of the nose and the palate. This would indicate a lesion of which of the following ganglia? Okay, so you have dryness of the nose and the palates. What are you going to guess? So the nose and palate are not working. Pause and think. The answer is C. So the postganglionic parasympathetic fibers originating in the pterygopalatine ganglion innervate glands in the palate and the nasal mucosa. So you can see over here, the pterygopalatine, cranial nerve number 7, lacrimal and nasal palatal glands. Right? Then we move on to a 43-year-old man has a new onset of difficulty with speaking. Examination by the ENT resident reveals problems in elevating the hyoid bone. For the man, secondary paralysis of the posterior belly of the digastric muscle. Which of the following nerves is most likely involved? Okay, so you have paralysis of the posterior belly of the digastric. We talked about this. It's one of the exceptions. So what is the answer? The answer is D. A 46-year-old man was a speech therapist complaining of dryness of the mouth. The therapist performs a swallowing study examination, finds the man has a lack of salivary secretion from the submandibular gland. This indicates a lesion of which of the following nervous structures? Lingual nerve at its origin, chorda tympani, superior cervical ganglion, lesser petrosal nerve, auriculotemporal nerve. Difficult question. Pause and think. Okay, so he just has dryness of the mouth, so just salivary secretion. The answer is B, the chorda tympani. So it contains preganglionic parasympathetic fibers. The superior cervical ganglion provides sympathetic fibers which supply blood vessels and submandibular glands. That's crossed out. The lesser petrosal nerve contains the preganglionic parasympathetic fibers, the synapse and the otic ganglion. The auriculotemporal nerve contains postganglionic parasympathetic fibers which are responsible for secretion of the parotid gland. Right? So the problem here is chorda tympani. During extraction of her impacted wisdom teeth, a 22-year-old woman suffers damage to her right inferior alveolar nerve. Which of the following conditions is most likely to result? So, right inferior alveolar nerve. Okay, inferior alveolar nerve. So, compressor cheek, paresthesia, weakness in closing the jaw, decreased salivary flow, salivary, reduced taste in the body of the tongue. The answer is B. That's pretty much it. All right, alhamdulillah, we're done. Inshallah, I made everything clear. If there's any mistakes, I'm sorry. Please do let me know so that we can fix that in the slides. Um, I made the slides as comprehensive as possible. And if there's any questions, please don't hesitate to email me. This is the Q&S. Please rate the session on here. And that's it. Thank you. Any questions?